Alright, today's period instruction will be over neonatal care. It's actually going to be split up over basically 3 days. We'll be covering topics starting from NRP, which is Neonatal Resuscitation Program, moving into the stable and just general care of infants as well. Covering a whole gamut of the difference in anatomy and physiology, how we're going to treat neonates different than even infants, and infants different from adults. It's going to be a relatively in-depth course, and a lot of these different subjects I pulled from different areas, such as NRP, which is an AHA book, although it's mainly regulated to nurses. Decent amount of flight crews have that certification as well, or electrical care crews. But it's been wanting to. The medical directors within Las Vegas have talked about trying to get more people at least following AHA NRP guidelines, particularly with the newborn infant. Overall objectives are going to identify the need for neonatal resuscitation, assessment management of the neonate, management of neonatal resuscitation, the transport of a neonate, recognition of injuries associated with birth, and recognition of genetic anomalies present in some neonates. And that's really going to be our third kind of area that we'll look at, is some of the different congenital areas that some of these neonates will have. So there's some different abnormalities that they'll do. Some of them are known prior to birth, some are not. We're going to take a look at a decent amount of them and what we can kind of do with them. It's kind of sparse through the second and third part of these this PowerPoint. Definition of a neonate is a neonate or newborn. We'll also see that newborn or neonate is relatively interchangeable throughout this lecture. Occasionally try to differentiate that if it's literally the baby just popped out, and we'll talk about that baby versus a neonate that's a couple weeks old. But neonates can be classified by being less than 28 days old. Neonate care begins immediately after birth. Neonate and pediatric care can be similar, however, especially with neonatal resuscitation, along with some other things. It kind of is a little bit separate than our standard care that we see given. So, and we'll go into that into detail, whether it is the respiration to pulse rates, how quickly we move to compressions, how even more so importance of ventilation, and ventilation is the more importance than even oxygenation at this point. And one other side note, as far as like the hospital is concerned, they can have a baby that's in the NICU for like 4, 5, 6 months, and it's still considered a neonate. However, they can send a baby home from having birth in the hospital, and when it comes back, it goes to the PICU, even if it's 5 days old. They consider it like basically a dirty baby, and it just kind of separates that way. So take a look at some of these as we go through. So our neonates, as far as that we're kind of concerned, are broken up into 2 basic categories. They have a couple subcategories, but we have a term newborn. Childbirth occurs after 37 weeks of pregnancy. And we have our premature babies, or preemies, and that is anywhere between 20 and 37 weeks. You will kind of find, as we look through all of this, anything usually below like 24 to 20, 24 is a real low limit, unless they're at the highest of quality NICUs, and even then, most of the time there's not a whole lot they can do. Even keeping the baby in utero for an extra week can increase its survivability substantially. So typically most preemies tend to be 26 weeks older. There's some variation to that, and they're able, and there's also always the exception, but there's not really any births that have survived below 20 weeks. And usually it's starting at 24-ish that they start really being able to stay alive. Risk factors associated for the need of resuscitation. Most newborns require no resuscitation beyond the maintenance of temperature and mild stimulation. 90% plus of babies need zero resuscitation at all. They come out screaming, crying, ready to fight the world. About 4 to 10 need positive pressure, and that's about it. When we look at the alveoli, they've never been opened before, and they just need that extra little help to try and bump those up. Only 1 to 3 in 1,000 newborns need chest compressions or resuscitative medications. And we'll even see the only medication we give for neonates is epinephrine as far as resuscitation medications. And it's at the very bottom of the list. It's not very often that we have to go this far. Resuscitation is more likely in newborns born prematurely, low birth weight, and in mothers with antepartum or intrapartum risk factors. So pregnancy risk factors or after risk factors. We'll kind of look at some of those. So, two newborns, when antepartum or intrapartum risk factors are present, delivery is imminent. Paramedics are prepared for neonatal resuscitation. In the hospital, they do this all the time. There'll always be usually someone from the NICU, usually a NICU nurse and maybe a PA or NP up there, almost on every birth. However, if there's any type of risk factors at all, they'll have a little bit more robust team and they'll be a little bit more prepared for resuscitative measures. And in the hospital, they'll have the L&D nurses that will be taking care of mom, and the NEO team will be there. The NICU team will be there to concentrate on neonatal resuscitation. So, questions we need to see if they're higher risk. When is it, or in general, but when is a baby due? So we can assess for prematurity. There's actually calculators even on apps or otherwise. It's a little wheel that you'll see in L&D. They can get pretty closely to when they're due. So remember, anything less than 37 weeks, premature. And we'll talk about some of the subcategories of like the 34 to 36 and 6 days premature. That's really, they're a bit tricky because they look like full-term babies, but they'll sneak up on you with some issues. And then below 34 weeks is rather immature, and 30 or below is real tiny preemie baby. So we need to determine when the baby's due and if this looks to be a premature labor, if the membranes have ruptured and was amniotic fluid clear, how many babies are expected, always a good one. You deliver one baby and all of a sudden someone mentions, hey, the mom's crowning again, something to be aware of. Also, all multi-term babies are, and one thing you'll see on your test is like multi-tip or multi-tip, and it's a term for multi-gestational. So multiple types are multiple babies, whether it's twins, triplets, quadruplets, so on and so forth. And are there other possible risk factors? Premature babies is kind of what I was talking about. Anywhere between 20 and 37 weeks. It's getting closer to 24, but 20 is the theoretical lower limit. Factors that increase risk for a premature birth include UTIs, STDs, certain vaginal infections such as bacterial vaginosis and trichomoniasis, hypertension, vaginal bleeding, and developmental abnormalities within the fetus. Anytime there's any type of abnormalities, and you'll see a lot of these be very similar throughout this lecture, they start having all these issues, we need to start being more concerned with it as far as neonatal risk factors involved as well. So different things, any pregnancy resulting from vitro fertilization, so where they have help medically conceiving, placental previa, where the placenta is over the cervix and as it opens it starts to bleed, higher risk factors. Diabetes mellitus and gestational diabetes, either of those increase those, and we get actually a larger than normal baby typically because insulin is a growth factor as well. Blood clotting problems, maternal age, younger than 18, older than 35 years old, any of that can cause increased risk, particularly the older ladies. They have a bit higher risk factors with them. It could still go no problem, but we just need to be aware and be ready to intervene. Previous preterm birth that happened once can happen again. Short cervix, short interval between pregnancies, not enough time for things to heal up. And then lifestyle factors such as low pregnancy weight or obesity, smoking during pregnancy, substance abuse during pregnancy, anything like that. If we have a patient that or the mother who used opiates and was still using them, we can expect our baby to come out and not breathe. We do not Narcan these babies. We typically just let them, we bag them and let them wean off of it. Prematurity can weigh anywhere from 1.5 to 5 pounds, which is a half key to 2.2 keys. A half kilogram kiddo is extremely small. It's going to be smaller than your hand. Smallest I've ever had was about a kilogram, and that baby was roughly the size of my hand. Healthy premature babies weighing more than 3.7 to 1.7 kilograms, about equal. They have an outcome about equal to those of full term. So premature is not a huge deal, particularly in this day and age. Just got to add that supportive care. Lower than that, we start having issues. Once again, 23 to 24 weeks is where the fetus really has a chance. But even then, it's a lower chance. But we increase 1 week even, and all of a sudden the mortality rate starts dropping pretty significantly. So things that we need to be looking out for: some of these premature babies have an increased risk for respiratory depression, hypothermia, and brain injury from hypoxia. They're vulnerable to changes in blood pressure, intraventricular hemorrhage. The small neonates, when we even would transport them across, or in the helicopter and move them across the parking lot if it was on the ground pad, just the bumpy asphalt could cause some of these kiddos to have a bleed in their brain. Some of the really small neos are very, very sensitive to everything. It's why they are nice and safe in the mom's womb, but as soon as you get them out there in the vibrations and the real world, everything makes it a whole lot more difficult for them. Most have short extremities, less subcutaneous fat, and thin, non-keratinized skin that appears translucent. They have lack of sphagnum in their lungs, which makes it more difficult for them to ventilate. They have a hard time opening their alveoli and keeping them open. And it increases risk complications from positive pressure ventilation. Their lungs are much more easier to pop is the issue. It doesn't take much, and when you're already dealing with someone who has that should only be getting about 60 cc's of air, and you give 65, we have a chance of just easily blowing those lungs up. Not actually blowing up, but popping a hole in them, causing a tension pneumo. It's something we need to be very cautious of with these babies. So when we look at prematurity and how we take care of them in the pre-hospital, it revolves primarily around airway and circulatory support, maintaining their temperature, which we will get into pretty deeply. Hypothermia is a huge concern that we need to make sure we are on top of. Some ways that we can prevent hypothermia. Wrap the baby in a plastic wrap with a cap. This does not mean a brand new, healthy, full-term baby we put in a trash bag. It sounds like a joke, but I brought this up the very first time I taught this, and the next station that someone went to, they had a grocery bag ready to catch the baby directly. Not what we're talking about. Typically less than 32 weeks, some type of polyurethane plastic bag. As you can see in this picture over here, they wrap, particularly if the skin looks at any bit translucent, they are not able to maintain their heat very well. So we need to go ahead and try and use whatever substance we have at hand. It can be a plastic bag wrap that we have in the truck. It can be anything. What it does is it just helps retain the heat very, very well. And then we also need to make sure that we put, most of our kits tend to have these little, or many of them have like a little beanie or something like that, because the baby tends to lose a lot of heat to their head. Warm, humidified oxygen, apply radiant heat. The heat pads that are in the back that come in that come with the OB kits are in our truck somewhere. Use those. I still put a towel or something underneath it because they're not meant to get very hot enough to burn the kiddo, but since their skin is so thin and doesn't deal with heat very well, along with the fact that there's always manufacturer issues, just throw a little bit something between a sheet, a towel, lay it down first, just so we don't burn the baby. Heat packs, I would definitely wrap up if for whatever reason we have to use one of those. Heat packs tend to be quite a bit a little bit warmer than those thermal pads, so definitely use that. Temperatures greater than 100.4 should be avoided. Also, huge thing with keeping our baby warm is drying them off. They now have a fluid, they have amniotic fluid because they've been inside the mom all this time. We need to dry that off, otherwise we deal with evaporative air and convection cooling properties, and heat loss. So that's where we need to try and keep our kiddo as warm as possible. We'll get into the nitty-gritty of that here in a few. All right, so some of the physiological adaptations at birth. The newborns make 3 major physiological adaptations that are necessary. So they'll empty fluids from their lungs. Their lungs up until this moment are filled with fluid. Much like you guys ever saw The Abyss back in, I think it's the early 90s. When it first came out, they would fill, down in the bottom of the ocean, they filled up their tanks with some special fluid that allowed them to just transfer oxygen via a fluid medium instead of air, and so they didn't have to deal with pressure issues. But basically their lungs would become entirely filled with fluid, and that's where these babies are, because the primary way that they get oxygen is not through breathing like you and me when they're in the fetus. It's through the placenta and through blood through their mother, and so the lungs have never opened up before. So you have to think of it as a parachute kind of coming out, and it hasn't fully deployed, so we need to get the good positive pressure. Many times they'll be able to do it on their own. However, if they're not, that's where positive pressure and ventilation really comes into. They'll change in the circulatory pattern. We'll get into it just a minute when we talk to Dr. Sartorius and how it changes because the lungs were not used in the past. The pulmonary circulatory systems, basically, it was used enough to keep nutrients going to the developing lungs, but it was not used as a primary means like it is for people outside of the womb, in that we're not getting that oxygen exchange through there. So what happens is, once through that period of birth, there's a extra little, it becomes basically a ligament later, but it bypasses the pulmonary circulation, and they'll move, and we'll get into it next slide or two here in a moment, but they'll move to a normal circulatory pattern where they're now involved in their lungs, and the majority of babies lose the function of the ductus arterius. So now they also have to worry about maintaining their body temperature. And as soon as the umbilical cord is clamped, the baby transitions from maternal oxygenation to its own spontaneous breathing. And if they don't, that's where we come in. So the physiological adaptations at birth, there's a number of things that start to happen. During the labor, adrenaline within the fetus as well as the mom, but activates within the fetus, activates sodium channels and reduces an increase in catecholamine levels that trigger this clearance of amniotic fluid that's in the lungs. Basically, sodium channel, chloride channel turn off, and sodium reabsorption begins, which causes a shift in fluids. Water is reabsorbed with the sodium. It follows wherever the sodium goes, and causes about 1/3 of the fetal lung volume to be cleared prior to the baby even being delivered. Further clearance occurs during vaginal delivery when the newborn's chest is compressed. We have that compression of the chest causing some of that fluid just to come out of it as well. And then it gets out into the nose and the mouth, and that's where some of our suctioning is rather important when it's needed. So here we have basically where we talk about the ductus arterius and the foramen ovale. What happened? Normally the foramen ovale right over here we see is this opening that allows, because the lungs aren't oxygenating blood as the baby's heart's beating, it doesn't matter which one it comes out of, just due to as blood comes in, goes through the heart, and it comes out, the ductus arterius, the blood flows over into the aorta, because the lungs don't need very much blood. They need enough for growth and to keep blood there, but it's not the same purpose as it is because it's not aiding in oxygenation and ventilation. However, upon birth, now that those changes are seen differently, and for whatever reason, this diagram it's flipped upside down. Don't worry about that. This is the better one, and the during the birth, both of the foramen ovale and the ductus arterius start closing, usually particularly pretty well over the first 10 minutes. But with that, it happens kind of a little bit slowly, and sometimes, and there's certain birth defects that it can happen quite a lot. One other thing is reason that we'll throw on a pulse ox on our right wrist and then somewhere on either of the feet. 'Cause at that point, it doesn't necessarily matter. Some people always want the left foot, but it's not as big of a deal. We can see here where the ductus arterius closes or attaches to the atrium, and it's after typically it's somewhere right around there with the atrium. So some of the left wrist will get some of that deoxygenated blood. The right wrist definitely gets it. So that's going to give us our preductal arterial saturation. And further down as it gets there we'll get our normal left ventricle blood flow, but as well as the mixing of the preductal or postductal blood from the ductus arterius, which causes a difference in blood sediment. That comes into factor a little bit later when we're trying to identify or help us identify somewhat what is going on as far as our some of the heart issues. It can be either preductal or postductal. We can take a look at some of that. So during labor, the first breath is in response to chemical changes, the exposure to the air, changes in temperature. All of this causes these physiological changes throughout the body. As air enters the alveoli, pulmonary capillaries dilate. The blood starts to flow into the lungs. The baby now is reacting to this, having to breathe for the first time, and now moving to pulmonary circulation like everyone else in the world. So circulatory transitions from that normal pathway, and the foramen ovale closes, and the ductus arterius is a little bit closer. And sometimes it takes, particularly like the foramen ovale, it might take a little while. And the ductus arterius, like I said, about 10-15 minutes. A normal baby, newly born, may not reach oxygen saturation by measured by pulse ox of 90% for at least 10 minutes. And there's a chart when we look through at NRP that will really see this. So here's a kind of view of this the blood flow through. They both go in through the right and left atria. They come out. That foramen ovale is open, and it just kind of allows blood to flow out of both our right pulmonary arteries and our aorta. And then because that ductus arterius up here is big and wide, it all just kind of mingles. Blood saturation in the fetus is typically, on average, it's pretty hypoxic. It's about 85%. And they live in a little bit more acidic environment, somewhere closer to about 5 millimeters of mercury less. So their pH and that pH would not be millimeters of mercury, but their EtCO2 or their PaCO2 would be closer to 30 to 40 versus 35 to 45. And their pH will be 7.3 to 7.4. Slightly less, about 5 less, but overall, and so they're just used to dealing with a slightly more hypoxic environment. Once again, a little bit of blood flow does go to the lungs for keeping for growth and keeping the cells nutrients.
So next, with another physiological adaptation at birth. One thing that I briefly brought up previously was the shift of water at the beginning of labor due to the movement of sodium caused by the release of epinephrine. When to the left here, we can see the sodium and water chloride all in the alveoli that are filled with fluid. as the epinephrine hits, it causes the sodium shift to move out, and the water will tend to follow that. With that, we're going to have a little bit of K shift, a little bit of water shift. If you remember, the type 1 cells are what make up a pretty big majority of alveoli. The type 2 cells are also what creates surfactant, and babies that are younger or premature tend to have uh, issues with their surfactant production, and they don't have enough yet. So with all this, just here's kind of an intracellular histological level of how the fluid moves out with the introduction of uh, adrenaline at the beginning of labor. During labor, it may take several hours for the fluid to completely exit, for the ductus arterius to close, and for the foramen ovale to close. Your O2 set can stay, particularly in the first 10 minutes, 70s to 80s, even in the low 90s after a while. It takes a little bit for the body to fully adapt there. And the younger they are and the more premature they are, the longer sometimes that can take. So newborns are sensitive to hypoxia, much like our pals. One of the biggest issues that they have is not that they typically have heart issues. Now, when we talk here later in this chapter about the congenital heart issues, yes, those are a thing, and you start studying neonates and you think it's a huge thing, but it's not that common. Many times they're able to find it beforehand anyway, so they're pretty well prepared about it. Some of them they don't. Some of them they don't find until after birth or several months after birth. Tetralogy of flow is one of those that can be found way late. However, hypoxia is an issue. Now, you also will hear me say multiple times that we don't want to give too much oxygen to kids, particularly the small preemies. Being said, in resuscitation, after we're not able to, when we get through all this and we've kind of gone through the initial ventilation steps and we're not getting any, or if it's a full cardiac arrest, go ahead and give them oxygen. Being said, as we go over this, just know that ventilation tends to be more important, particularly in the very first few breaths, and open up those alveoli. That is more important. But some different causes of hypoxia will include compression of the cord, difficult labor and delivery, maternal hemorrhage. So talking about compression of the cord, we're just not allowing enough oxygenated blood from the mom to come into the fetal circulation. So she's not going to, even though the mom might be trying to get enough oxygenated blood to the baby's not receiving it due to compression of the cord. The cord could be somewhat of a nuchal cord, but most likely something the baby pushed up against it. The cord is presenting into the birth canal. There can be a number of different ways that compression of the cord can happen throughout the labor process. Difficult and long labor and delivery, that's just a lot of stress on the mom. Mom will become hypoxic, or she'll be using up most of her stores, particularly in the first deliveries where some of the labors can last up to 36 hours, just going on and on and on. The baby's going to start feeling some of that distress. Maternal hemorrhage kind of makes sense. When we talk about maternal hemorrhage, the mom's she doesn't have enough. We're already talking about there's a less hemoglobin, or our hematocrit values are down because there's less red blood cells for the total plasma volume there is. While they gain up to 50% of extra plasma and fluid during pregnancy, they don't have nearly as much gain in hematocrit and red blood cells. So if she starts losing some of that, the already low hematocrit and the low oxygen carrying capability in relation to the total plasma is already lowered, and it's going to get worse with hemorrhage. Next, with maternal drug use, this is all over the place. Any type of things can cause that. Anything that can cause hypoxia with the mom can cause hypoxia with the kiddo. There's a number of different ones. If we have any questions specifically, go ahead and ask me about what specific drugs can do. I probably don't know all of them. Come with an idea for a couple. There's just so many different types of drug use is a very broad term with uppers, downers, all types of different things that can cause different physiological reactions to the body. And airway obstruction makes sense, right? If mom isn't getting enough oxygen, the baby's not, and even when the baby's born, if they don't have airway moving after the placenta is no longer feeding blood to the baby, whether it be us not suctioning, it could be a malformation of the fetus. There's a few of those that we'll go over that are congenital. That'll be later in the airway section. And then there's it could be meconium sustaining, and we'll talk about that here in a few minutes. Also, hypothermia. I go pretty deeply into hypothermia and and we'll focus on that here in a few, and we'll kind of break that down. Newborn blood loss obviously makes sense. It could be from the raising the baby above the placenta, so more of the blood drains down out of there prior to clamping. We usually want to lay them very even. Sometimes it's slightly lower, maybe, but most of the time they say hold the baby pretty level to the placenta. But there could be other bleeding loss, if there could have been uh, maternal hemorrhagic prior to what we were talking about with like placenta abrupta or placenta previa. Number of things that can cause that. And immature lungs, obviously, if the lungs aren't able to really move oxygen and air very well, that's going to cause an issue. As I said, we're going to talk quite a bit about hypothermia, at least in this first part. Hypothermia is very important to try and address with these kiddos. The next couple slides will look over some of the different physiological changes and how it's just very detrimental if we don't keep these kiddos warm. So one of the big issues is they have a much larger body surface area with not a ton of thermogenic, the ability to make more heat, body tissue inside of them. They have some, including brown fat and a couple things that we'll look over, but they don't have ability to shiver. They don't have a ton of internal body warmth themselves, and so they lose heat pretty quickly, and they're not able to maintain it great. So we want to dry them off, warm them up, and keep them nice and warm. Otherwise, we're going to have this cascading effects that we're going to talk about here shortly. We want to try and bring these kiddos in a place where there's not a lot of cold air or any air moving at all, because even if it's decently warm air moving, it's still moving across the skin and it's taking away the body heat that is kind of radiating off the skin, and that can cause an issue. We'll talk about that in a minute. So it's going to be convection, radiation, a number of things. Put a little cap on those kiddos if we have them, and try and keep them warm. So we're going to talk about something called the golden minute. Much like trauma, we have our golden hour. Golden minute is going to be the very first minute of life. This is where we give the kiddos a chance to kind of come around. They might not be as active initially, and we need to try and support them as best we can. Do some of these initial life things. After that golden minute is when we start really looking more into the resuscitation side of things. This first little minute or so, it's that huge transition from being in the womb to being in the real world, right? It's a big difference. So when we talk about being ready, we need to have everything that we can. Sometimes it catches us by surprise. Mom's like, yeah, I just have a slight urge to push, but it's her sixth kid, and it comes out. I've seen it happen in L&D. Doc didn't even have her both gloves on, and mom started pushing, and the baby just almost shot out. It was crazy. Caught it with one hand with one gloved hand. But so make sure we have everything that we can ready. Have the OB kits, have extra towels there, have the warming pad. The more prepared you are, talk it over with your partner on what needs to be done, whether it's your partner, your EMT partner, or the other medic on scene, or the whole engine company. Just be ready to go. So that first minute, try and get everything set up. The initial steps in assessment, especially those who require, should be following AHA, and NRP is made by the AHA. This is where we start differentiating a little bit from PALS, and there's a bit of discussion with no great consensus on when PALS ends or NRP ends and PALS begins. That being said, NRP is especially important for the brand new neonate. The question on when it ends or not ends is closer to the end or a few weeks after, and there's not a lot of consensus about it. But talk about that later. So the whole thing about the golden minute is in that first 60 seconds, after the first 60 seconds, we want the baby to be ventilating well. Whether hopefully it's on their own, and if not, we're ventilating for them at this point. That golden minute is really important for completing like the initial steps and getting that kiddo a chance to kind of breathe on their own, even with our assistance, but trying to help with suction, stimulate, maybe a couple quick rescue breaths to kind of help inflate the alveoli to see if that kicks in. And most of the time, that's all it takes. If not, it's after that golden minute that we really start moving to a resuscitation side of things versus just a little bit of helping the kiddo along. So immediately following the delivery, kiddo comes out, and we start our evaluation and answer the questions we kind of are. These are different than the initial ones where we were trying to get idea of what they're looking for, or what issues mom could have, and the delivery itself. Once the baby's out, we want to make sure one is a baby term. It's kind of the same as the first one, but still important. Preterm versus term kind of dictates a little bit of not necessarily our full-on actions, but really preps us to be a lot, if it's a preterm baby, ready to really do a lot for the kiddo. Does the newborn have good tone? If you guys remember in class, I've been kind of having you look at our little sim baby, and good tone. Are they moving around a bit on their own? Are they laying completely limp? Are they screaming and yelling and grabbing hold of things? Tone. Their overall muscle movement. They don't have very much muscles, but they will scream and they will move around. Yell or crying isn't necessarily tone, but that ability to move their arms, legs, and all that is what we're looking for. Tone, and then breathing and crying for the airway. If the answer is yes, term, yes, baby has good tone, and yes, breathing or crying, particularly for crying, we're going to go ahead and hand the baby off to the mother. We'll go ahead and dry her off, and we're going to go ahead and place the baby on the mother's chest. Cool thing about that is physiologically, when the mom has the baby on her bare chest, the mom's body will adjust to the temperature to try and warm that baby up. It's a really cool adaptation, and it's how we've been delivering kiddos for thousands and thousands of years without all of this crazy technology and heating pads and all this. If they don't have any issues, just lay it on mom's chest. Great for bonding, but it also really helps with the warmth factor. Remember, dry them off prior, pat them down. That's it. And drying them off is a fantastic stimulation as well. Just kind of rub them down with the towel, get them out of there, and make sure we try and get as much moisture off as we can. If the answer was no to any of those, not term, no poor tone, or not breathing or crying, then we're going to do one or more of the following in these sequence. Our first one is going to warm and maintain, trying to maintain a good normal body temperature. Like I said, dry the baby off, try and stimulate the baby somewhat with the towel. Sometimes a little bit of flick on the bottom of the foot can work very well. It's not anything crazy, but it gets that little bit of stimulation going for the baby to kind of wake up. Make sure if they're clear secretions, and there's not very much of them, we don't tend to do very much with suctioning. And when we're talking about suctioning, we're using our bulb syringe. When we do we do work on making sure that there's no other secretions. If we notice any meconium staining at this point, we don't do deep meconium staining suctioning anymore. However, we still get everything out of the upper airway. And by deep, that would mean put in either an ET tube or basically, yeah, we don't even use a soft suction. What we used to do is put in a the ET tube after intubation, attach a meconium aspirator, which I'll have in class and I'll show you guys, and then we try and deep suction out. Meconium is very, very thick and very, very sticky. What meconium is where basically the baby has a bowel movement due to the stress of the labor process and causes the bowel movement to basically get or go all through the amniotic fluid, and it just becomes this very thick and viscous fluid, and it's not necessarily even fully fluid. It is horrible to try and deal with. These kiddos actually don't do well. So we'll get more into meconium aspiration and that here in a few. But as far as we'll suction a little bit if needed, even particularly if there's copious amounts of fluid, dry and stimulate. If that doesn't work, we're going to go ahead and oxygenate and ventilate. We're not going full non-rebreather. What we try and do, most of the time they've kind of moved to where it's almost room air or about a half a liter per minute on a BVM, just because what they need right now is pure pressure. They just need to expand those lungs. So by adding that PEEP in there, just a light PEEP, a little bit of pressure in there, even if you don't have a PEEP valve, just a little bit of BVM, because if you guys remember ventilation lecture, PEEP it assists recruiting, but it's not necessarily recruiting itself. So nice soft breaths, try and get there. We're looking for approximately 40 to 60 breaths per minute. So one good way, and this is going to be the same way that we'll do our compressions as well. But if you want to go your count for breathing, particularly initially, you can try and give a couple breaths, and then wait to see if that helps. Many times that's all they really do need. But if they do need a little bit more, it's going to be 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. So it comes out to like roughly about 40 breaths a minute. And that's kind of right where we want to be at. Be very cautious with our tidal volumes. All we're looking at is our chest rise. Please don't pop these babies' lungs. If that doesn't work, we'll start the rest of it. We're going to talk about chest compressions, and then finally epi and volume. So it's in this order: that perform these initial steps, then we'll move to ventilation and then oxygenation, followed by chest compressions, and finally epi and volume. Sometimes volume's needed more than epinephrine, but we'll get into that here in a few. So for even healthy terms, they have a getting back onto the hypothermia side of things. They are limited in their ability to conserve heat when they're exposed to a cold environment and at risk for hypothermia. One, they just have way more body surface area than they have total than adults do. They lose that body heat pretty fast. They can't generate it on their very much on their own, particularly our preemies. Not only is their skin thinner on our preemies, they have less brown fat, and brown fat is super important. We'll talk about that here soon. And so the recommended ambient temperature for newly born non-asphyxiated babies is 97.7. But kind of how we talk, pre-warm towels work great if your radiant warmer isn't working. That radiant warmer or the warming pad that we have, many times they sit in the back of the ambulance or underneath somewhere and somehow get activated way years back and aren't that fantastic. We don't want to overheat these kiddos, but we want to keep them warm. So if that happens, if you do for some reason have no heating pad and it's really cold, look at the hot packs, but please wrap those in towels and make sure there is a cup of multiple layers between the heating pack and the baby. Those things get a lot warmer than those heating pads do. Make sure the head and body are dried thoroughly, and then get rid of the wet towels and put new ones on. And then if we have any type of cap, hopefully you guys do. I know not everywhere does. We had a lady out in Flagstaff that her whole thing is she would knit a bunch of those caps for our Neo team and for all of our bases, so it was kind of cool. We always had these crocheted hats for our kiddos. All right, so talking about the golden minute on the airway. Biggest thing, you'll see, I'll show you the full-on algorithm. So this is the NRP algorithm. I kind of break it down part by part by part in each area. So the first area, the first minute, that golden minute, we want to clear that airway. Or prior to that, we can look up here is the antenatal counseling. We're talking with our team, if we have the time to, figuring out who's going to be taking care of mom, who's going to be catching baby, who's going to be leading the baby care. Depending on if the mom's in a not fantastic condition due to whatever other reason, sometimes we need to split our efforts and one person take care of mom, one person or the other side of the crew will be taking care of the baby. Next, ask the good questions as the baby comes out. Term gestation, good tone, breathing or crying. Yes. Mom, after we dry off the baby, put baby on mom's chest, call it a day. Obviously, we're still going to reassess, but we're not worried about the resuscitation part anymore. If that doesn't work, if not a term, good tone, or there's no breathing, we're going to warm, dry, stimulate, position the airway, suction if needed. We clear the airway. We want to make sure that many times that'll try and stimulate the baby enough, just moving the airway, getting them in that right position. And as you guys have kind of figured out on those mannequins, baby airways are a bit sensitive. That's why we have to try and be very cautious on their head tilt, where everything's angled. They don't have a lot of muscles to hold it up in that to maintain that. Their trachea is very thin. There's only one ring that goes all the way around in the cricoid, or it's way up high in the cricoid, and the rest is just not formed very well, so their airway can collapse relatively easy. We have to be aware of that positioning. They're not breathing. First clear the mouth, then use a bulb syringe to clear secretions, amniotic fluid, then the nose. Their babies are, we call it obligate, but they're preferably nasal breathers. So if we clear the mouth first and then clear the nose, we're going to, when we clear the nose, hopefully cause him to breathe up through their nose. We want to clear the mouth first because if there's more secretions in there, if they go to take a deep breath, we don't want them to not necessarily aspirate because their lungs are already full of fluid, or partially. But we just want to try and get clear of that. And then add positive pressure ventilations. So talking about the meconium staining, it's present of fetal stool in the amniotic fluid, occurs in utero or and in about 12% of all deliveries. Carries an increased risk of mortality, hypoxia, aspiration pneumonia, pneumothorax, and pulmonary hypertension. Most common in post-term newborns, so late-term newborns, or those too small for gestational age. There'll probably be an area in here where I'm going to start calling it SGA for small for gestational age, or LGA for large for gestational age. There's a couple different ways that babies can be predispositioned to either small or large. Or the other risk factors, newborn stress before or during delivery, and that can be due to trauma, extra stress, long deliveries, number of factors that can just cause the baby to become extra stressed during this, cord compression, things like that. Normally clear amniotic fluid, not a big issue. However, that meconium stain gets all in there. They'll get it in their airways, and then they'll have to try and deep suction that out. It is not fantastic. So a newborn meconium stain often has poor muscle tone and adequate breathing. Positive pressure ventilations priority. Routine intubation for tracheal suction is no longer recommended. That's why I said we'd tube the kiddo, attach the meconium aspirator, and try and deep suction that out. We didn't have very much luck through it, and it just didn't work very well. So if they inhale any of that, do what we can. These kiddos don't do very well overall. They can definitely get through it, but they have a relatively high mortality rate. Tactile stimulation to initiate breathing. While this photo's up here, because it's what at least they say they used to do, we don't do that anymore. Please don't hold the baby like that. That's how you drop a baby. And if you do, you drop the baby, fall on the ground, and act like you're seizing. Just kidding. Don't do that. But we do want to, first, the best tactile stimulation is just the drying of the kiddo. Next, sometimes like flicking of the feet, a little bit of the bottom, causes enough of a kind of response with the kiddo to get them going. If that doesn't work and they're still not doing, we can try and stimulate a couple other ways, but after that, we're going to start looking at more ventilation and working on that. Rubbing the baby's back, trunk, and extremities. We don't want to do this any longer than 30 seconds during that golden minute. All right, next, what we're going to do is we're going to talk about the golden minute and the APGAR. So after the first minute has passed, we take our first APGAR score. Our APGAR score is taken at 1 minute and a second time at 5 minutes. The one at 1 minute typically isn't always that great. It can be fine, and sometimes it can be rather low. It's going to be anywhere from 0 to 10. We look at APGAR. It's just an acronym for appearance, pulse, grimace, activity, and respirations. It's scored either 0, 1, or 2 for each of the letters. A good score is somewhere between 6 and 7. That's pretty decent and not a big issue. Anything below that, we're definitely worried about looking at resuscitative measures. And really, we don't get at 10 hardly ever, even at LND. One of the docs that was teaching me mentioned that they never give that because typically there's always something small going on. 9's even semi-rare. So looking between 6 and 7. When we'll kind of look at some of the very specifics of it. We'll talk about appearance. Blue or pale all over. That's a 0. Blue extremities but pink body, 1 point, and that's actually pretty normal. Sometimes they'll stay like this for a couple of days to even a week or so. The peripheral cyanosis, not a crazy big issue. And 2 points for body extremities, pink with no cyanosis at all. That's one of the ones that can be a little bit more uncommon because typically a lot of the babies end up having a little bit of a bluish tint to a more grayish tint looking at cyanosis. Pulse, 0. This is a bigger one. 0 on pulse, not great at all. Less than 100 beats per minute, we're going to start ventilating, which we'll talk about in a minute. Greater than 100 beats, we're good. Grimace, talking about the response to stimulation. They have no tone. They're floppy. They're unresponsive. 1 point would be grimace on suction or aggressive stimulation. They start waking up and they start crying at you, things like that. Crying on stimulation is what we're really getting. So grimace are kind of moving around with 1 point. Crying on stimulation is 2 points. Activity, no activity. So if they have some flexing of the arms and legs, 1 point. Active flexing and against resistance, 2 points. And respirations absent, 0 points. 1 point is weak, irregular, and slow. And then 2 points is crying and screaming. So typically on a pretty healthy one, you're going to see a smattering of 1 to 2. And we're more worried about that second one. We basically want to see an improvement between the 1 minute and the 5 minute checks. It said 7 to 10 is normal, 6 is even not horribly, depending on who you listen to. But 4 to 6, something that we usually need a little bit extra, and then less than 4, we're going to get deep into our resuscitative measures. So newborn should be assessed, 60 seconds to decide if resuscitation is needed. If a problem arises, follow NRP guidelines to optimize the outcome, and then initial steps, reevaluation, and begin evaluation should occur within the first 60 seconds. So at the end of that first minute, if the baby is not breathing or the pulse is really low, we're going to go ahead and move on to the lower parts of our algorithm, which we'll look at here in a minute, and just kind of move on from there. So here's that first initial slide. Move down, first 1 minute, go. We warm, dry, stimulate, position airway, suction if needed. Is there apnea or is there gasping? And is the heart rate less than 100? If yes, we're going to move further down. If no, we're going to move down here in a second again. So this is kind of the next step. So count quickly for a respiratory rate and a pulse rate for 6 seconds, multiply by 10, and that'll give us one of each. So our respiratory rate, we're really looking at 40 to 60. Anything lower than that's not ideal. If it's lower than 40, be prepared for ventilate to assist some ventilations, and then go ahead and move on. If normal breathing pattern and pulse is greater than 100, we just kind of allow that to go, but maintains the central cyanosis and trunk and mucous membranes. Just a little bit of extra oxygen. We want to be cautious with too much oxygen. It can cause blindness in some of these preemies. So in the preemies particularly, it can still cause some damage in infants, in just regular neonates. If apneic or pulse rate of less than 100 beats a minute, and after 30 seconds of drying, we're going to go ahead and initiate NRP. So here's the next, and I'll show you guys the full outline here at the very end. After that 1 minute, positive pressure ventilation if the heart rate's less than 100. If it's less than 60, we're going to go straight to compressions. If it's between 60 and 100, positive pressure ventilation. Consider a cardiac monitor. Most of the time, it's not a cardiac in nature. It's most of the time a respiratory issue because they have no oxygen at all, because they haven't been breathing ever in their life. If it's labor breathing or persistent cyanosis, just look at positioning, airway suction, pulse ox, and possibly CPAP. We'll talk about some CPAP things in class as well. If the heart rate's less than 100, ensure adequate ventilation. ET, consider endotracheal intubation. It's kind of hit or miss here. Sometimes BVLS airway is the way to go on these. If the heart rate's less, take whatever steps we need to. If the pulse rate ever drops below less than 60, whether it starts less than 60 or it starts dropping there as the resuscitation, as we're ventilating them or anything else, at that point we're going to go ahead and begin chest compressions. They talk about the 2-finger method. Yes, that is an approved way, but if even you look at how we do most things these days, we're very strong with our thumbs. Whether it's using phones, doing all types of things, our thumbs are pretty strong. You're kind of hand wrapped around the baby and using your both thumbs to compress. You get usually a bit better control as well as depth with that. So consider that. However, if 2 fingers works, go for that. Use a pulse ox when resuscitation is anticipated, baby appears cyanotic, or if we're having an event ventilator patient or not. A lot of times, if you just put the baby on the chest, we don't always need to get a full set of vitals. In the sense of a full cardiac monitor, try and see what we have for SpO2, but you're not going to fit one of our little clippy SpO2s on them. If you have one of the sticky ones that can go around and put it on their foot, you'll see how that kind of works. It tends to work a lot better. If once we're starting to resuscitate, once we're doing compressions, then the high flow O2, something that's when we're moving to high flow O2 because at this point they're down. Anytime we're moving past just that initial positive pressure ventilation, PPV at the very top where we're just trying to help inflate their lungs, yeah, just a little ventilation without O2 is usually kind of what's needed. However, when we're doing resuscitation due to low heart rate or less than 100, then we're looking at oxygen. Or less than 60 when we're really doing those compressions. We're going to go ahead and go through 2 minutes compressions. Nothing happens. After that, heart rate's still less than 60. Now we're going to start looking at our typical codes. We're going to code drugs. Epinephrine, and by typical code drugs, it's epinephrine and fluid. That's all we give. Consider hypovolemia, consider pneumothorax. Here's our med list. It should be the same that's on a Broslow, guys. Our epinephrine, 0.02 milligrams per kilogram, rough estimate. And the newest dosing, they actually adjusted it to almost a straight one across for all Neos off of the 8th edition. However, 7th still pretty good. Just kind of go with that. And this might be one time that we actually give meds via ET tube. The issue here is trying to get IV access on a neonate is very hard as it is, particularly if it's going to be a preemie. Super difficult. IOs, we have a very high possibility of going right through the bone. And they also have a high, just due to the lack of calcification of their bones, have a chance of the IO coming free anyways. So if that's the case and we need to give epinephrine, the dose is 0.1 milligrams per kilogram right down the ET tube. While this is a not the last resort effort in a ACLS and neonates, it's still regularly accepted and just due to the difficulty of establishing IV access. So you can still try the other ones, just know it's hard. If ventilation chest compression does not improve the bradycardia, administer epinephrine, preferably via an IV line. Once again, not always there. If no signs of life, pulse, respiratory present after 10 minutes resuscitation, chances of successful resuscitation are very low. Overall outcomes associated with it is high mortality. So something to think about, and we might have to have that conversation with the mom and the kid. We are the mom and a doc trying to figure out, and the parents figure out what we need to do. If there was no signs of life at all, these things happen, but it doesn't have a very high chance of them coming back after that. So focusing more again on the hypothermia aspect, hypothermia can be associated with perinatal respiration depression. So skin to skin with mother covered in a blanket. Skin to skin, once that baby's on the mother's chest, her chest will actually change temperature to get the kiddo at the temp it needs to be. We still want to get a blanket over them so we don't have the convection cooling off the kiddo more than is needed. And we're looking for that 97.7 to 99.5 degrees or 36.5 to 37.5 Celsius. Make sure the head and neck are properly positioned for an open airway too, guys. So we talked about the neonatal physiology and the ductus arterius as they kind of change in that first 10 minutes. If you throw an O2 set on the right hand, which is going to be our preductal area, that's going to tell us that the blood coming out of the aorta is going to be a little bit lower, or should be a little bit higher than the left side due to the unoxygenated blood yet mixing via the ductus arterius. And so initially the blood's going to be at 1 minute. If you see the SpO2 at 60 to 65, that's what we're shooting for. That's fine. Don't freak out. 2 minutes 65 to 70, 3 minutes 70 to 75, 4 minutes 75 to 80, 5 minutes 80 to 85. Around 10 minutes is we're really looking to get in kind of normal areas. And so the initial oxygen concentration for our positive pressure ventilation, this is not in the full resuscitative mode. This is just when we're breathing for the patient by itself, is equal or greater than or equal to 35 weeks gestational age. We'll just give room air. If it's 35 less than 35 weeks, we're going to go ahead and give 21 to 30%. So a couple liters in your BVM, and that's all we need. We're not trying to give high flow. Once again, if we're doing compressions, high flow, different story. So, reviewing positive pressure ventilations. If respirations are inadequate with bradyapnea, gasping, or apnea, if the heart remains less than 100, 30 seconds after completing the initial steps, positive pressure ventilation should be initiated. Assisted ventilation is 40 to 60 minutes to achieve and maintain a heart rate greater than 100 beats per minute. Approximately 5 centimeters of H2O of PEEP is recommended. Use of CPAP or PEEP should be guided by medical direction. Whatever they say we have. PEEP works fantastic for these kiddos. The newborn's heart rate should initially be assessed in the first 15 seconds with a quick pulse check in the brachial. Make sure, and then we're going to be checking again after ventilation goes. We don't want to hold on to any check pulses anywhere too long, otherwise we can cause lack of circulation issues going on. So, positive pressure troubleshooting. They have this thing called Mr. SOPA. If positive pressure doesn't seem to be working, Mr. SOPA is going to be your friend. First, we're going to do is mask adjustment. Try and get the mask set up. Make sure we have a good seal. Next, we're going to reposition the airway. After that, suction mouth and nose. Then open the mouth even wider and try and just positive pressure through the mouth. If that doesn't work, a little bit increased pressure, slightly by whether it's a little bit more volume, a little bit pressure. Don't go too much, just a little bit more. You can squeeze a little bit harder on the bag. Do not just squeeze the entire bag as hard as you can, but just a little bit harder than you were doing to try and see if that helps. And then if that doesn't work, we're going to look at an alternative airway. So next up, we're going to talk about the advanced airways and which ones to use. First off, we're going to go over LMAs, or laryngeal mask airways. On the screen, you can see a couple of them. While we may not have them on the truck with us, we should hopefully have some. I believe Fire might have the air cues that are this small, possibly not. They're not used that often, so a lot of units don't want to. And due to many times, or the big chance that we'll not use those, we do not always stock these. We do have ET tubes, so we can use those. But if your service has any of these, it works great. On the A is just what they call a cuffed pharyngeal seal. It has a cuff on there, and it kind of seals up the entire airway. And just due to the different anatomy of the the neonate airway, that's why it looks even different than a typical LMA. Our air cues still look pretty similar. Shouldn't be any big issues there. No big changes. LMAs, or sorry, not the LMAs, but the iGels, kind of the same. Supraglottic airways work really well with these kiddos. Many times they actually usually recommend these for most people. And they go down to pretty dang small. They don't necessarily have the full preemie sizes, but they do have them all the way down to small neonate sizes. Talk about ET intubation. Maybe indicated several times. Remember, guys, we don't have very much practice on this, much less practice on a full preemie baby. Not many places actually do a ton of training with these in depth. We had one because we had our Neo team, and it's quite intimidating because even that little mannequin we had was barely bigger than my hand, and it was different and kind of hard to intubate. The infant is pretty close to what that was, but it's still a little bit different there. I've talked to you guys in the past a little bit about the sizes and where we go off of, but we're particularly talking about neonates. Here's a nice little chart which is on NRP, which you guys can look at. Remember, small neonates get 2.5. Small preemies get 2.5. Smaller neonates get 3, and full terms usually get 3.5. All of these almost are always uncuffed still. Infants, on the other hand, is when we'll get into the cuffed airways as we get a little bit bigger. Our fours, four and a halves, five and a halves, and up are usually all cuffed these days. You guys might still have them. It's not a big deal. Just kind of note the difference. When we're going to go ahead and do this, when tracheal section of meconium is required, which we don't do really anymore, so it's not really that required. But if we're going to need to do that, we'll go ahead and tube the kiddo. When chest compressions are performed, anytime we're doing chest compressions, we should probably look at trying to get a tube at some point. Remember, breathing is more important than the tube, or is more important than compressions most of the time here, but if the baby's not perfusing due to a slow heart rate, we still need to make sure compressions are being done. And then for special circumstances such as congenital diaphragmatic hernia or extremely low birth weight, so less than a kilogram. Diaphragmatic hernia will be in one of the things that we talk about towards the end of this lecture when we talk about congenital issues, and it needs a tube and only a tube. That is one where LMA is not sufficient. Paramedics should verify tube placement visually during intubation using primary and secondary confirmation methods like we'd always do. Prompt increase in heart rate after ET intubation administration of intermittent positive pressure ventilation is a good indication of correct tube placement, as one would imagine. So here is the entire algorithm all in a row from when I just pull in different parts of it to look at it. So if we look at it from the very top, going to do our team briefing, equipment check. Birth comes out, term gestation, good tone, breathing or crying, give it to mom. If not, warm, dry, stimulate, position, airway, suction if needed. If there's apnea or gasping, no. Breathing, persistent cyanosis, we'll position airway, suction if needed, pulse ox, O2 if needed, consider CPAP. And then post-resus care, team debriefing. If there's apnea or gasping, or heart rate's less than 100, positive pressure ventilation, pulse oximeter, consider cardiac monitor. If that doesn't work, we are going to then heart rate less than 100, consider good ventilation, ensure good adequate ventilation, consider ET tube or laryngoscope mask, LMAs, and cardiac monitor. If heart rate drops less than 60, then we will start chest compressions, tube the kiddo, get 100% of O2, and UVC. UVC is a umbilical vein catheterization, so it's an IV through there. I'll kind of talk about it and ways that we can use that. We don't really have the equipment to do a true one. We can go over that, but we'll talk about that in class some. If the heart rate remains under 60, then we will start epinephrine and we'll look at hypovolemia or possibly darting a kid. Hypovolemia, it's typically 10 mLs per kilogram for neonates. All right, that's decent about a review. And once again, the thumbs is probably the best way to do it. The 2-finger on the chest is not a fantastic. It doesn't do that great. Not a lot of studies one way or the other with this, but the goal is we're going to be delivering this at a rate of 3 to 1. So 3 compressions to 1 breath. This is the biggest difference between here and PALS. 3 to 1. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. We are going for a heart rate of 120 minutes to 120 second total, or for our total ratio. So it's going to be 90 compressions and 30 breaths per minute. The reason that that's important is because they have such a high respiratory rate and a high need for that ventilation that we need to increase the amount of ventilations that we're giving these kids. Here's a video. And that's it. I don't know why I showed this twice. All right. So compression should be continued for 60 seconds before reassessing the heart rate for less than 60 beats per minute. Frequent interruptions of compression should be avoided because they will compromise artificial maintenance and maintenance of systematic perfusion and maintenance of coronary blood flow. I've kind of looked at this and talked about this in PALS and ACLS that we need to make sure the blood is flowing, and by taking too much time during our breaks during compression can cause a lack of that stop of that blood flow. So compression is more important, but it's 1 and 2 and 1 and 2, 3, and breathe. 1, 2, 3, and breathe. 1 and 2 and 3 and breathe. Right. And once again, 2 thumbs encircling the chest is the preferred method. Drugs are rarely indicated for the resuscitation of a newborn. Drugs should be administered only at the heart rate below 60 beats per minute, adequate ventilation, and 100% oxygen, and effective compressions aren't doing the job. Should be infused through IV access if possible. However, if it's not, ET tube epinephrine is appropriate. Please don't give volume resuscitation through a tube. Please. All right, recommendation dose is 0.5 to 0.1 milligrams per kilogram for ET tube route. Obviously, IV is great, but if it's small preemie, we might have an issue there. Once again, dosages are here. Kind of look at it rapidly. We'll talk about giving the dose via, and we've done it during PALS of using the stopcock method. Works fantastic. And then volume expanders for isotonic crystalloid fluid, so NS, is going to be 10 mLs per kilogram in IV. Indicated for shock, give it for 5 to 10 minutes. When administering drugs or volume expanders, that's everything I just said. I don't know why it's 2 slides in a row. Saline works. It is fine. You'll see in NICU when you guys do your clinical rotations, sometimes they give weird fluids. NS or half NS, so 0 or 0.45 NS. D5 water, D5 NS. They give all types of different things there, and that's up to the NICU doc or PICU docs. So cool. NS works for us. Don't worry about giving too much sugar unless we have low sugar, which we'll go more over in the staple portion. When we look at a umbilical catheterization, here's where we're looking. If we can see on a catheter, we don't have the full special catheterized kits. What I was always taught too is you can use just this side of the umbilical, feel for the big vein. You'll have 2 smaller ones, we can see right up here. The 2 smaller ones are the arteries, and the one larger is the vein. You can also feel this on the side of that and attempt to start it like you would start a normal IV, and it tends to work relatively well. We don't really have the full umbilical vein catheterization kits, which have a couple interesting things. You can see on here they have a little tie to build up a little tamponade for that, much like a tourniquet that we'd use for IVs. It can work decently. ET tube route for drugs, IO can work, and then IO definitely works. Umbilical vein can only be accessed if allowed by local protocol. I don't believe our local protocol says much one way or the other. You could, we'll go over it some more in class. So post-resuscitation complications. The most common complications include ET tube migration and dislodgement, tube occlusion by mucus and meconium, pneumothorax. Complications should be suspected in the presence of the following: decreased chest wall movement. Obviously, if the chest isn't moving up and down nearly enough, can cause some issues. Diminished breath sounds, makes sense, right? Bradycardia. Anytime that the bradycardia returns and it was fixed initially by proper ventilation, the first thing we should assume is some type of ventilation issue arising. Could be a pneumo, could be mucus, it could be any number of things. Many times it's going to be a tube displacement. Remember, because we're using this uncuffed tubes in here, they are easily dislodged. If it dislodges and you can't see it easily to fix it, try VLS airways initially, and then try and get the babies resuscitated enough and see if before trying an intubation attempt again. If they're kind of crashing, you can go straight to ET tube again, but let's try and get them resuscitated as best as possible. We see that unilateral decrease in chest expansion. Assume we need to dart. Altered intensity to pitch of breath sounds. If all of a sudden the breath sounds change, we can assume it could be some type of lower airway obstruction or issue. Increased resistance to hand ventilation. You can start noticing that. If you start noticing that increased ventilation change, go ahead and make an adjustment. Once effective ventilation and circulation has been established, newborn and mother should be transported to an appropriate facility. Call ahead. Most likely you'll be going to L&D. They might let you know, particularly if there's special circumstances like a trauma involved. Go to the appropriate trauma center and deal with them there. L&D doc's great, but if the baby's already delivered, the L&D doc doesn't necessarily need to be there now. They need to NICU and PICU, most likely. Being said, if they have a hospital they want to go to, go ahead and take them there. If you have to resuscitate, we'll follow our same, still closest, most appropriate hospitals. Warm ambulance, even if it's in the summer, make sure it's warm in there. Administer warm oxygen if available, cover head and apply warm blankets, maintain oxygen levels, and support newborns' ventilations. Continually assess and monitor newborns' respiratory distress for treatable causes. Asystole and pulseless cardiac arrest are uncommon in the newborn. Usually result of hypoxia, primary secondary apnea, unresolved bradycardia, persistent fetal circulation, which we'll get into, and that's where we're talking about the ductus arterius doesn't want to close and the foramen ovale doesn't want to close. They have medications that can close, although there is some congenital heart defects that need the ductus arterius to stay open, and so have another medication that will maintain the ductus arterius patency. Otherwise, the kid will code because they have a congenital heart defect that'll cause that. And we'll go over those in the congenital heart side. Peripheral assessment findings can include peripheral cyanosis, inadequate respiratory effort, or ineffective or absent heart rate. Asystole and pulseless cardiac arrest. Congenital malformations can cause a congenital neuromuscular disease. Drugs administered to or taken by the mother. We can give medications. It could be pain meds. It could be magnesium, which would give, say, for a patient who is eclamptic and the baby comes out because it is a smooth muscle relaxer and it causes central nervous suppressant with mag toxicity. The baby can come out not wanting to breathe very well. I've had this happen. Intrapartum hypoxia, intrauterine asphyxia. Either way, we're going to continue on, and these are some of the ways that can cause any of the issues we have. All right, next, we're going to talk about stable. I know I kept mentioning going into in-depth physiology behind like hypothermia and some of the others. Stable is a lot more broader of a class. NRP is the resuscitation side of it. It's AHA, so it's going to be like ACLS or PALS. While that is, it's very algorithmic, shorter, and meant to deal with a patient who is crashing or crashed. Stable has more to do with the neonate that we need to transport. Could be sick, could be critically sick, but isn't coding yet. If the neonate starts to code, we fall back to NRP. But here we're going to get a little bit more in depth about all of the different issues that neonates can have. So neonates stable stands for sugar and also safe care, temperature, airway, blood pressure, lab work, and emotional support. We'll go over most of these, some a lot more in depth than others. Okay, so starting out, if the infant's sick, don't give oral or gavage feedings. Provide glucose via intravenous fluids. They just need sugar. They don't necessarily need much in their stomach. Many of the time they'll just try and throw it up, and then we have a chance of aspirate them. Some neonates, and many of them are at risk, and most of them are at risk pretty easy. They don't have very much stores, and then some are at high risk for it. So we need to be checking their sugars. And that's why the first letter of Staples S. Three main factors that impact glucose after birth: inadequate glycogen stores and decreased production. So they just don't have the stores, whether it's glycogen or just glucose, and they're not able to produce glucose. Particularly with preterm infants, the late preterm infants. These are the ones that I said are tricky. There's a 34 to 36 weeks of gestational age. They look like a full-grown baby, but they have a few issues that causes them to be tricky. The less than 34 weeks, they look like preemies, they act like preemies. We kind of expect that. The 34 to 36 weeks can be okay, or they can act like preemies, but they don't look like preemies, so it can be a little bit tricky there. SGA infants there's two different types. There's symmetrical and asymmetrical growth patterns. We'll talk about some of those. Hyperinsulinemia. This suppresses glucose production and increases glucose utilization. Too much insulin in the blood causes the cells to uptake too much insulin, and now they don't have enough glucose stores to know how to be able to deal with things after that. So, if they have hyperinsulinemia, they will burn through all their sugars, and then they don't have any stores to back it up. Or increased glucose utilization, such as sepsis, some type of infection or illness, that can all cause an increased use of glucose and then cause them to be hypoglycemic. So, inadequate glycogen stores or decreased glucose production. Some of the fetal factors that can cause this: chromosomal abnormalities. They can just have issues that cause this, to include chromosomal and genetic. They can have certain syndromes, metabolic disorders, and uterine viral infection, especially early in gestation, or multiple gestational births. Twins, things like that. Twins are almost always smaller at birth. I haven't dealt with anything more than that. And so, but the smaller the more babies there are inside, usually the smaller they all are together. That's why Octomom, if you guys remember that back in the day, her babies were all in the NICU for a long time and they were tiny. Maternal factors that can cause this: nutritional status during and before and during pregnancy. Sometimes not everyone, whether they took prenatal vitamins or they just weren't able to eat quite enough. Chronic illness, hypertension, diabetes with underlying vascular disease, cyanotic congenital heart disease, renal disease, anemia, chronic pulmonary illness factors. Anything can cause, as you can see, so many of these things can cause different glucogen issues. Sometimes, we'll go on to some more of these. Some different uterine factors that can cause that. Impaired placental function in particular, where there's an inability of the placenta to deliver appropriate nutrients and oxygen to the baby. So, and things like preeclampsia, hypertension, and diabetes. Injections of drug and toxins, as always. Prescription medications used for chemo, hypertension, anticoagulant therapy. And then there's different types of genetic and familial factors for small infant size, or chronic physiological stress of the mom. So, infant of a diabetic mother, they usually have LGA, or large for gestational age infants. Because insulin is a growth hormone in itself, they're exposed to more insulin than normal during pregnancy, and they can increase size. And then afterwards, they have this increased size without the stores to back it up, and so they can become hyperinsulinic when the cord is cut, and we got to be very on top of that. All sick infants, whether they have some type of infection and any type of shock, if they have any type of any of the congenital heart diseases or in respiratory issues, if we have to provide resuscitation, hypothermia and hypoxia, anything like this, they can cause them to be have low blood sugars. So general findings for hypoglycemia on there, because they're not going to tell you I feel weak. Abnormal cry, weak high pitch is the cry is weak and high pitch. Poor feeding, hypothermia, diaphoresis. Neurological signs, they got tremors, jitteriness, irritability, lethargy, seizures, cardiorespiratory signs, tachypnea, apnea, cyanosis. Kind of the same things that we'll see in kiddos, even adults. Got a hangry baby. Don't need you guys to memorize this graph. Being said, I put it up here if you guys want to save this, but it's pretty interesting. And this is what they will start many of their IV infusion rates for glucose at, with the different concentrations of D10, D12.5, D15. I think I have the next one goes up to D25, I believe. And where they start out, and then their milliliters per kilogram per day, and then that also goes over to their actual infusion rates. All right, next, temperature. I said we'd get more in depth with it, and here we are. Hypothermia is a preventable condition that has well-documented impact on morbidity and mortality, especially in preterm infants. Maintaining a normal body temperature must be a priority whether neonates are well or sick. It doesn't matter if they're coming out healthy and all this, and they're screaming, crying, moving around, throwing things at you. Dry them off, cover them up, even if they're on mom's chest, cover them both up, keep them all warm. It must be a high priority. Normal core, like we want the core temps, they say normally above 36.5. We want to get above that. Mild hypothermia is 36 to 36.4. Moderate, 32 to 35.9. Severe, less than 32. That's all in Celsius. So neonates are at the highest risk for hypothermia. Neonates that are preterm or low birth infants, they have nothing. They have no stores. They have no insulation, and they are already struggling along. Small for gestational age, similar. Infants who require prolonged resuscitation, they don't have enough circulation going out to their extremities, so they're getting cold. Now their whole body's getting cold, and it's going to go to the core. Infants become acute with infectious cardiac, neurological, endocrine problems, usually because that also causes a similar issue of being in shock. Infants with surgical problems, especially infants with open body wall defects such as gastroesthesis. Facility, I always have a hard time saying this. We'll show it to you an example of this. And exposed spinal defects where heat occurs more rapidly. Once again, these are all congenital issues we'll talk about towards the end. Infants who have decreased activity or hypotonic from sedatives, analgesics, paralytics, or anesthetics. Anytime that they've been sedated or paralyzed, they're going to be more have a higher chance because their body is not generating more heat. So, term infants who are cold, stressful, physiological respond and generally conserve body heat. They will vasoconstrict. Prolonged vasoconstriction causes reduced blood flow and oxygen delivery to the tissues. This increased risk of developing an anaerobic metabolism, and lactic acidosis results in organ and tissue damage. That being said, they also are able to use brown fat metabolism. We don't have, as adults, very much, if any, brown fat. Babies are born with it, and it's very useful for this. It increases heat production. Brown fat is accumulated in increasing amounts throughout gestation. It accounts for like 2 to 7% of their total body weight, and it's usually all builds up in that last trimester. In cold stress, norepi is released. So when the baby's exposed to cold, it's released into in the nerve ending in brown fat, causing it directly to be metabolized. Brown fat is very, very energetic. It will bypass the blood as it goes by, and it is one of the most effective ways for an infant to warm up. They don't have an ability to shiver, so this is how they warm up. Being said, if they are preemie, if you can look up there, they don't. It's usually because it's usually done in the last part of the third trimester. They won't have as much brown fat. If they don't have as much brown fat, they are at a higher chance of hypothermia. And this isn't even the smaller preemies. This will also count just our late preemies, our 34 to 36 weekers that look normal, don't have that translucent skin yet. But that skin's not the only issue here. It's a lack of brown fat too that causes it. Increase head production and heat production and decrease body heat loss. Infants have poor or no capacity to shiver. Instead, their activity, they'll cry or they'll flex their arms and legs. They don't actually shiver, but they can cry. They don't have very little muscles. They'll still grab on and hold on to things. I don't know how they can be as strong as that, but they don't have that crazy, they don't have an ability to shiver, and so they'll try and flex. The other thing that heat flexing does is it reduces their total body surface area by moving their feet up to their chest. Now it reduces the amount of body surface area that is exposed to cold air and allows them to keep more of their body warm. Getting in the fetal position has its purposes. With the onset of even mild hypothermia, the infant's metabolic rate increases to produce and conserve heat, increasing oxygen consumption and glucose utilization. If they're already experiencing respiratory distress, increased oxygen demand from hypothermia may lead to hypoxemia. There's a significant risk that the infant will convert to an anaerobic metabolism and increase lactic acid production. Not fantastic. So, the cold stress will progression to hypothermia will cause a cascading set of events that explains the increased morbidity and mortality in these guys. So, the In response to that cold stress, the hypothalamus releases norepinephrine, protective mechanism to keep the body's core uh, blood away from the skin, where the heat is dissipated. With the lack of perfusion and anaerobic metabolism, the pH will decrease. Acidosis also contributes to pulmonary vasoconstriction and right to left shunting, because what all that means is that the pulmonary arteries and veins will start constricting, and so all the blood is going to try and start backing up. That then causes them to become hypothermic even faster, just due to this very large surface to area body ratio, decreasing amounts of insulating fat, then our immature skin, increased insensible water loss, particularly if they're breathing and they're tachypnic, they're breathing off more, and then poor muscle tone and little, if any, brown fat. This is why preemies are in such a high risk category. So when we get this norepinephrine and pulmonary vasoconstriction, which increases vascular resistance in the lungs. So then we're not getting as much oxygenated blood from the lungs back out to the body tissues, which causes an increased amount of lactic acid buildup because the body tissues are now hypoxic, which causes a further increase of as all this starts to happen. Then the blood shunts from right to left through the ductus arctus and the aorta instead of the lungs, and so it's just bypassing the lungs almost altogether, causing deoxygenated blood to flow through the body, increasing hypoxemia, which causes pulmonary vasoconstriction and worsens right to left shunting. With increased oxygen demand and increased body usage, the infant then uses more glycogen stores, which causes their sugar to drop even more. Since glucose is the primary energy source of the brain, they start to lose consciousness, and decline, respirations will slow, and oxygenation will worsen, and you're going to get hit with a snowball the size of you. This is a issue we need to address as soon as possible, guys. This is why hypothermia, I've been stressing from the beginning, is so important in our neonates. If you get nothing else from all of this, this is why it's important. This is why the flight crews, or even the ground critical care crews, carry the isolate. It has all this other cool things kind of to it. It's heavy as heck. The thing that is important here, out of everything on there, is that it keeps them warm. That's what an isolate's for. All this other stuff, meh. They got medical air, O2, ways to mix. They got an air mixer here, vents, monitors, 4 different syringe pumps, plus other stupid helicopter helmets. All that's important here is to keep this temperature warm. That's what an isolate's primary goal is. That is what it does. So now you know. Convection heat is swept away by air currents. Keep the air from reaching the patient's skin. Using swaddling, infant can, for the preterm infant, cover the patient with food-grade plastic if we need to. Use of an isolate for interfacility. Obviously, we don't have these. This is interfacility stuff, not what we're worried about. Evaporation occurs when moisture on the skin or respiratory tract is converted to vapor. Cooling effect then, as it's pulled away, as the moisture evaporates, it pulls away heat with that. Dry. Cover their head if you don't have a beanie. Keep them warm. Put a blanket over kind of them. Increase room temperature to reduce air temp gradient. Keep the back of that ambulance nice and warm. Heat and humidify to additional oxygen if we're given any. All of that fun. Radiant heat loss is the loss of transfer heat between solid surfaces that are not in contact with another, right? It's just the heat just radiating off, like the pavement in the streets of Vegas during the summer. It just kind of radiates off. Now, if you add wind and air movement, then you have convection with that, where it's slowly coming off, but then you have wind moving that radiating heat off of that, and then it causes the heat underneath to radiate more, and that's where radiation and convection come together. Rewarming the unintentional hypothermic infant. So there's very little research here, guys. Current practice states rewarming should not exceed 0.5 degrees Celsius per hour to avoid sudden vasodilation hypotension. And then to have pressors and volume expanders readily available in case of hypotension. However, The 0.5 per hour rule has not been scientifically evaluated on the unintentional hypothermia where this rate may be impractical. As in, we need to warm this patient up or they're going to die. That is ideally what they would like, but it's not always possible, and there's not a lot of evidence behind it, and that is from their Stables book that says that right there. So there's that. Warm them up as best we can. All right, moving on to stable airway. We went over some of the airway stuff before, and neonatal resuscitation, stable airway is a little bit, just going to go a little bit more in depth with that. Respiratory failure in the neo can occur rapidly. Respiratory support ranges from providing supplemental oxygen to increase levels of support via high flow nasal cannula, continuous positive airway pressure, and non-invasive ventilation or endotracheal intubation. So all the things we talked about earlier, now more in depth. So assessing neonatal respiratory distress in a neonate, we're going to look at their respiratory rate, their work of breathing. Do they have all the things we've talked about? Do they have the nasal flaring, grunting, retractions, presence of cyanosis, whether it's peripheral or central? Once again, central cyanosis is a lot more concerning than peripheral cyanosis. Their O2 sets, but we have to take that along with how far along they are after birth. If this is a transport that they've been home for a few days, hopefully that's not a big enough issue. And if it is, we still need to be aware of it. Chest X-ray is cool. We don't do this. So here's a neonate's chest. Looks very similar to an adult's, but oh so different. And then their neurologic status. Make sure they're anal 4. All right, respiratory rate. Normal rate for neonates is between 30 and 60. Once again, right out of the womb, 40 to 60. But we're talking up to that 28-day period, 30 to 60. A fast respiratory rate is anything greater than 60 beats per minute. Slow respiratory rate, anything less than 30. Those are some hard numbers that you can kind of go by the upper and lower limits when we're talking about bradypnea or tachypnea. Increased work of breathing. Nasal flaring. Signs of air hunger. The infant tries to open their nose, and increase the amount of airflow in. Grunting is their attempt to increase their functional residual capacity, basically fighting PEEP to expand their lungs and to keep more air in their lungs. Monitoring pre and post ductal gas and O2 saturation. Pre-ductal O2 saturation is measured on the right hand because that is if you remember, before it's coming right out of the left ventricle into the aorta, and it's before the ductus arterius up in the aortic arch comes into effect. So the right hand or arm will show their pre-ductal. The post-ductal could technically be in their left, but we usually put an O2 sat on their left foot and right hand. It can be on either foot because it doesn't necessarily matter as far as which foot. And if there's a difference in saturation 10% or higher, between the two sites, there's concern. And depending on which one's higher and lower can kind of tell us whether it's going to be or what type of heart issue they may have. For us, it's just pure conjuncture. They need further care, but it can give us down a pathway that might be something congenital going on. If right hand is approximately 10% higher, it's probably a right to left shunt. Blood is using the ductus arterius, and it's basically pushing unoxygenated blood to the right side. Right side to the left side. If both are equal but lower than expected, possibility right to left at the foraminal valve. And then if the right hand is 10% lower than possible transposition of the great arteries. This sounds about as concerning as it should. Not a great deal. We'll go over that in a few. So, talking about cyanosis. Peripheral or acrocyanosis, which is another name for it. Like I said previously, kind of can be pretty normal in the first few days of life, up to a week or so, but we can't rule out the cold stress side of it. Central cyanosis, when we're looking at tongue and mucous membranes along with the trunk, very concerning. We need to really be worried about oxygenation. It represents that desaturation of arterial blood secondary to respiratory cardiac dysfunction. Big issue. We need to try and fix it. Blood gas evaluation. It's important to evaluate the degree that stresses infants experiencing. Like I was talking earlier, guys, the pH will be between 730 and 735 and should adjust to normal range within about 48 hours. There can be multiple causes of pH and blood gas involved. Most involve around acidosis and areas that whether it's metabolic or respiratory, but of both, and how we can try and fix those. We obviously won't have access to ABGs, but it's something to note of. Metabolic acidosis. You guys should know generally um, how this works, but just to review, anaerobic metabolism secondary to shock, poor tissue perfusion, or oxygenation. Anytime that we have to start doing resuscitation, or that they're not perfusing well, we know that they can be in a state of anaerobic metabolism just due to a lack of circulation issues going on. Hypothermia, hypoglycemia can both cause this as well. Hypothermia, all the blood shunting to the core, having that same issue. Hypoglycemia, they're not able to, they're just trying to run off whatever they have, right? Severe forms of congenital heart disease can cause several forms, can cause severe hypoxia or left outflow tract obstruction, and sepsis, and then inborn errors of metabolism. Any of these can cause some metabolic acidosis. We're going to first just try and treat it with oxygenation, see if that works. Hypertension and shock, we're going to try and hit volume infusions, blood pressure medications such as pressors, and corrections of anemia. Heart failure, and pressors that we'll use, local protocols, dopamine, but epinephrine is also a very great one. Typically, we could use a few others, but usually we're kind of limited on overall pressors. We don't do a whole ton with those. Heart failure is treated once the primary cause has been identified, whether it's infection, structural heart disease, arrhythmias, hypoglycemia, or electrolyte disturbances, trying to figure out what's actually going on. There's so many things, much like adults, we got to figure out what's actually causing it to see how we can fix it. Till then, we're just going after symptoms. CO2 retention can result from inadequate ventilation. So we have loss of tidal volume, can be from a lung disease, pneumothorax, or airway obstruction. Any type of lung disease can cause this. Pneumothorax, obviously, we know that we lose our total tidal volume due to air being in the pleural cavity and it pushes that over. That's how we have a loss of air. And any type of airway obstruction, because we have either partial or full, and we're just not getting air moving throughout the chest with that. Loss of respiratory drive is very common in preterm or very sick infants. Preterms, like the 30-week or 29-week I had, just didn't have a huge drive to breathe. Part of it was, I think, we believe because her mom got a bunch of mag right before this happened, as well as they just don't have that drive yet sometimes, so it takes it. All we had to do though was just occasional ventilation support, as opposed to full on breathing for them for every breath. She was doing decent, just would stop breathing occasionally. Other times you can have neurological injury, whether it's a hypoxic ischemic encephalopathy, neonatal encephalopathy, structural brain abnormalities, ischemic or hemorrhagic stroke, and all this can lead to respiratory depression or apnea, as well as medications that the mother induced, to include narcotics. Renal compensation. How we're going to try and fix that? Retention of bicarbonate for elevated PCO2 is a slow process. We know the kidneys do it over a long process. However, it does take them a while to get there, but they do get there. The kidneys. So until then, we might be supporting via ventilations, possibly a little bit. Nothing that we're going to do in the field, but they might get bicarb or something in there. They're going to be real cautious with things like that. Many times ventilation can fix it until the kidneys can catch up. Positive pressure airway pressure, whether it's by bag or CPAP or intubation, will rapidly fix respiratory acidosis, and it'll even help us address metabolic. So that's kind of where we're at as far as those. Respiratory support. So there's a few of them above. This is a nasal CPAP because they are primarily nose breathers. Nasal CPAP works pretty fantastic. At Guardian Air, we had this device called a RAM cannula. What it would do, you can see them sizing up the little nose holes to the appropriate nostril size. And what it does is it provides CPAP just through the nose. These work fantastic. We even use them on adults sometimes. it just provides this positive pressure constantly through the nose. Because the infants typically only breathe through their nose and neonates, um, it seals it. Those holes are meant to be sealed up all the way. It basically closes off the nostrils like a CPAP mask does, but just allows positive pressure. Cool thing about those too is that it can connect just to a nasal cannula, or you can pop off the very end of it right up here, and it'll connect to a BVM. So you can use that to provide positive pressure ventilations without having to put a mask on a kiddo. It was fantastic. It's a really cool device. They can use high flow nasal cannulas as well. There's a couple number of different devices out there. Ram cannula is amazing. So talk about BVMs real quick. When we talk about NRP, they'll always talk about the T-piece resuscitator with its mask. It's this little device over here. We don't typically use those in the field, but it just connects right up, and you can provide PEEP with it, and you just push this little button down, and it provides a jet or push of air in there up to a certain pressure. Flow inflating bag. These are seen a lot. These are fantastic for this. This is one where if you don't have a good seal, this green bag will go floppy. They use these for all the way up to, they use these for adults and everything in the ORs. Very cool. Lets you know if you have a good seal or not, as well as you can just hold it onto them, and if they have an intact respiratory drive, because it's flow inflating versus self-inflating, that flow will go into the patient. Where self-inflating bag, what we have are typical BVMs. If we have this connected to oxygen and put it right over our patients, we are not doing anything for them. They get like a half a liter of O2. Hardly anything fully goes through. Flow inflating is different, but self-inflating, what we have by putting the mask over the patient, even if they have an intact respiratory drive, they are not getting any, or maybe just a hair of actual oxygen being flown to them. So plenty of other good reasons to use a BVM, but such as if you don't have oxygen, or it actually allows you to get a lot better BVM. It's why we use them in most places, but a flow inflating is pretty good. And this is the flow inflating is what we use primarily on the Neo team. So respiratory failure, when to move to an invasive airway. When are we going to tube these kids? If the infant's gasping, has periods of severe apnea and bradycardia, persistent bradycardia despite proper positive pressure ventilation, if they're hypercarbic, elevated PCA2s with moderate severe respiratory acidosis. No hard number, and in fact, these kids can do relatively okay for a bit of time being hypercarbic. But if we put this together with everything else going on, this could be a good indication on when to tube this kiddo. If they're unable to ventilate or oxygenate adequately with positive pressure ventilation, the infant is not a candidate for nasal or mask CPAP, such as us, because we don't have either, right? Unable to maintain acceptable O2 saturation for the infant's suspected disease process. If we don't think we can keep them at the adequate rate for what's going on, we need to tube them. Infants with some forms of cyanotic genital heart disease may have O2 sats less than 90 and do not require intubation or positive pressure ventilation. However, if they have a diaphragmatic hernia, which we'll look at here in a few, we need to ET tube them. That is the only answer. That's it. And we'll tell you why in a minute. Consult the receiving physician if uncertain whether the infant should be placed on CPAP or intubated, unsure about the ventilatory support to provide once it is intubated. So are we just going to be able to bag them? Is this going to be a very long time? As opposed to being able to put them on a vent, or if you have a vent for some reason, or if you're in a flight and have a vent, but your vent doesn't go to that patient's size, many vents stop at 10 kilograms. So if your baby's smaller than that, you're not going to be able to put them on the vent. That's an issue that people need to be thinking about. You guys, we don't have a vent anyway, so it's not a huge issue. Please don't put this patient on a vent. You will kill them. Or, so if we're calling it, if the infant deteriorates after intubation, get a hold of the doc. Here's another guide for ET tube sizes with the baby's weight. That's right, they are weighing babies in grams. That is a small baby. A half-gram baby, a 500, just not half-gram baby, that's insane. 500-gram baby or a half-kilogram baby gets 2.5. And you can see how I said all the way up to about 1,500 grams or kilogram and a half. Then they move to 302. 3.0 all the way up to 2.5, and then up and above. We move out of the 3.5s pretty quickly, guys. Then here's our estimated weight at what they're at, and you can see the 500 gram baby is typically one that is at 24 weeks. This is why any smaller than this, they don't tend to do well. So when we talk about laryngoscope blades, Miller 1 for a term infant, Miller 0 for preterm, Miller 00 for very low birth weight infant. We're talking about this real small preemies. We had double outs at Guardian, and I don't ever want to have to use that. The blade is about as long as my thumbnail. Not very long at all. It's a scary time for everybody involved. Stylets are optional, but available. As you guys seen me to these infants, I rarely, if ever, use the stylet. Kind of gets in the way. It's much easier just to do it for myself without a stylet. They do have some preemies for them, but really don't need it. We're not usually able dealing with crazy curves. Airway is actually a relatively straight shot once you get everything positioned right, and you can go straight in. So that's why you don't really need a stylet as much. Shoulder roll, money, and at neo-appropriate ETCO2 detector, it can affect tidal volumes on small neonates, something to be concerned about, but not excessively so. IGL size, if you guys have the smaller sizes, and the colors associated with them, 1 neonate, 1.5 infants, 2 and above. We'll go all down that route. They're all weighted. You can look at the weight and get a rough idea what you need to use. Great for, that is a fantastic way for most of these patients. Not great for the diaphragmatic hernias. The innervation views, we've seen some of these. You guys have practiced a little bit. Here's what we're going to look. We've kind of looked at there. We're looking at this tiny little hole that we're shooting for. The views that we're going to kind of get when you look at these angles over here, we can see how easily that trachea is cut off and why proper airway positioning is important, not only just to have them breathe in this normal position, but when we're going for the innervation, I'm trying to get that slightly hyperextended view just to get that straight shot in. You can see we don't really need any crazy curvature that we do sometimes with the adults. While they are more anterior, if you line everything up right, it's not the worst view. Just have to get your angles lined up right. Stuff I've talked to you guys from back in 131 in airway. So that is one way to secure tape on, and I thought it was a pretty interesting, relatively easy way to do that, because most of even our pediatric tube holders don't necessarily fit very well on a neonate. They might, and if they do, use them, and if not, tape is always a great way. I've learned a different way too, I guess, and shown in class. But I actually kind of like that way a lot. All right, ventilatory support. We have to, just much like on adults, kind of have an idea of what's going on to see what we need to do overall. Here's some initial settings that we can use as far as our initial rate. Um, Obviously, this is pure vent settings because this course was initially set up around CCT. Being said, some of this can still give you, we can take a couple ideas from looking at this and have a rough idea on how we can bag our patient correctly. So, start lower and then move up as needed. Our rate will start at anywhere from 20 to 40 on bigger babies once we get everything set up well, but 30 to 45 is a great weird place to kind of start initially. When the baby's just born, 30 to 60, 40 to 60. 40 is usually that good 1 and 2 and 3, breathe. 1 and 2 and 3, breathe. Now, when you have them on a vent long term, that's when they're making some of these adjustments, and that's where some of these vent settings are at. So kind of that one's by itself. Their eye time. Your typical eye time for an adult is 1 second. This is a third of that. So just kind of think of this. PIP, our positary inspiratory pressure, we're not really going to know that. If you have a manometer on the end of your BVM, you can see how high that first number goes. Never want to go above like 30-ish. 28's even the highest, we kind of want there. 15 many times gets us at chest rise and we're good. Our PEEP settings, if you have the ability to put our patient on PEEP, 4 to 7 is great. Start at 4 or 5. The 5 is a fantastic place to always start and adjust from there. Here's some dosage for our analgesic meds. So morphine we can give can cause respiratory depression, particularly a lot of these infants, even if they're tubed, they'll still have an intact respiratory drive, or at least partially. It'll be an issue as well as it'll cause hypotension. Fentanyl can cause respiratory depression, and as well as we need to be prepared to assist if they're intubated as well. And then there's a cool thing that they give is 24% sucrose solution. It actually causes analgesia up to a couple months old. It's a pretty interesting. A few drops of it will go on their mucous membrane, provide short-term analgesia for minor procedures. They'll sometimes put a pacifier in this, and so then they'll give the baby the pacifier, and the baby will start suckling away at it, and then it'll cause some analgesia. It's fantastic. Don't go give via the gastric tube, as there will be no effect. Having the baby ingest it's not where they get the pain relief. It's through the sucrose into the mucous membranes, which much like our other medications that get administered that way, it gets dissolved into the blood and it causes analgesic. Only give if they can protect their own airway. We had this on the helicopter. It was fantastic. So where we dart someone if we need pneumothorax. Pneumothorax affects term and preterm. It occurs when air escapes from the alveoli and pleural space and can occur spontaneous in non-intubated infants, no history of assisted ventilation or complications. This can happen. They have very sensitive lungs. It can happen. Kind of go in that same spot, fourth intercostal space, anterior axillary line. Just kind of go right down the same spot we do normally. Go ahead and dart the patient many times. And so how you can also set this up, whether they have it here with a butterfly, but you could also do it with just a normal syringe, have a syringe right on the end, kind of go in. We can just dart them like we normally do as well. And then we probably want to do those, make sure we seal that up afterwards, or we can throw a three-way stopcock at the end of our syringe. This might be the only patient I do this with. Other than that, that's kind of it. All right, congenital defects. I said we'd get here, and we're going to start. All right, we're going to start with some of the more benign ones. Or not benign, but non-cardiac ones. We have a tracheoesophageal fistula or esophageal atresia. So there's a number of things here that we can look at where there is. So this is how our normal airway goes down. Our airway's anterior, and it splits here at the carota. No issues. Esophagus is completely separate, goes in the stomach. Fun days. All right. Atresia with a distal fistula. What happens is somehow due to whatever genetic congenital issue, the esophagus attaches to the trachea, and there's a hole here, and the atresia ends. So the esophagus doesn't go down. Nothing goes into the esophagus. But the only way that they can get food is through their trachea. Not fantastic, right? Here's where your atresia connects to your trachea, then attaches out. Here's a big issue, right? And if you have stomach contents come up, it's going right into the lungs. Here, though, they'll eat normally, thinking it's going down to their stomach, and instead it goes directly to their lungs. Not a great day. Atresia with proximal fistula, the fistula goes in, the atresia is at the end of the stomach, so there's no attachment. They have no way to get food. This is what they're going to G-tube, but they need to fix this. Otherwise, every time they go to swallow milk, anything like that, it'll go straight to the lungs. Real bad. Here, not an airway issue, but there's no connection to their esophagus to the stomach. Here, we just have just a fistula and no atresia. There. So rarely found alone. 85% have both present. So that's some of the things that will cause it. All right. Congenital diaphragmatic hernia. This is what I talked about earlier. This is a intubation only thing we need to do. We can see here normally on the right, everything's normal. On the left. On the right, there's a hernia in their diaphragm, which causes their abdomen and chest, so usually a big portion of their GI tract, to include their small and large intestines, ends up in the thoracic cavity. It pushes everything over. If we start to include the stomach, and a lot of times the stomach is one of the big parts that come up. So if we are bagging the patient, or we have a supraglottic airway, we start bagging that. Air is going to go into the some of it's going to go into the esophagus. The esophagus goes down their stomach. The stomach starts inflating. It starts pushing everything over, and it makes everything worse. We might need to throw an NG or OG tube in this patient right quick and in a hurry. The life-saving NG OG tube, and this really could save this kiddo's life. And then we need to tube and make sure all the air is going into the lungs. Affects term or preterm infants. Onset of respiratory distress at birth or very shortly after. They'll be cyanotic and have a decreased sounds on the side of the hernia. The abdomen will appear sunken, and it's because their intestines are in their chest. It's a bad day. Immediate upon suspect or diagnosis of CDH, or congenital diaphragmatic hernia, stop giving BBM if prepared to intubate right away. Insert NGOG and frequently remove air from the stomach to prevent from entering the bowel, and it'll cause this kiddo to die. Airway congenital defects. We have conal atresia, affects term or preterm. We can see here basically what happens is there's a bone structure at the end of their nasal, because they're also primarily nasal breathers. They're not able to get air through here. Kind of a big issue. It's just a growth of a bone and tissue to the back, and it's blocked in their nasal passages. So affects females more than males. More than half the time they're associated with congenital anomalies, including congenital heart defects. The cardiac work was strong. Consider one or both posterior nasals blocked, or bony septum or soft tissue membrane. They may be cyanotic at rest, but pinks up with crying. That's due to them now breathing out of their mouth, but when they're at rest, they're trying to breathe through their nose, and they're unable to. So the only time they're able to keep going is when they start breathing through their mouth, and due to us not able to explain that to them, they have these issues. If bilateral conal atresia is present, the infant may be severely cyanotic at rest or experience severe asphyxia. OPA being necessary. NPA is obviously not going to do anything, guys. If conal atresia is suspected, gently try to pass a 6 French feed up through the nares. Inability to pass a tube mandates further evaluation to rule out conal atresia. Pierre-Robin syndrome affects term or preterm infants. We have this very large tongue and undeveloped small chin. They have arched and cleft palate many times as well. We can see up through here their small palate is underdeveloped, and so their nasal kind of goes right in here. These are very, very difficult patients to intubate. Very difficult. As many as half of these infants also will have a cleft palate. A respiratory distress may be mild to severe. Turn the infant prone. This will help the tongue fall forward by gravity. If the airway is obstructed, insert an NPA. Combined with prone positioning, NPA is often effective for maintaining an airway. However, NPA is not adequate. LMA is another alternative. Because of the very small jaw, endotracheal may be technically very difficult to perform. Probably try not to intubate these kiddos if we can help it. See if we have a supraglottic. If we need to try, go for it. But It's going to be a hard one. Now we're just going to tour off to the rest of the congenital ones since we started here for airways. Anomalies of the heart. And so defects in the heart structure that occur during embryonic development, most common birth defect affecting 4,000, so with producing hemodynamic effects and altered cardiac function. Some of them are unknown. Some it's genetics, Down syndrome, smoking, alcohol use during pregnancy, maternal rubella, and pre-hospital care. Our goal is to provide comfort measures. Surgery might be alternate required for some of these. So when I talk to that left to right shunt, I've mentioned it a few times. This is what we're talking about. The physiological effect is that oxygenated blood is shunted from the left, the systemic side, to the right to be oxygenated again. It creates redundant circulation, leads to increased venous return from the lungs, associated with volume overload on the left ventricle and circular pulmonary decreases. On here, here's a picture. So we have our systematic. We have our vena cava coming in. It's with our deoxygenated blood. However, there's and for this example, there is a septal wall and the ventral septal wall defect, and oxygenated blood, which just came from the lungs, gets mixed back up into the right ventricle, then goes back into the pulmonary system, and so it starts causing a number of issues with this. Coarctation of the aorta. This is a interesting one. So as we look right here, we have our normal heart. Coarctation of the aorta is where we have this narrowing of the aorta, typically kind of on this distal side of the aortic arch. It's very narrow. Usually has to do with a ductus arterius issue. Comes in, goes through. However, there's this backflow into the left ventricle from blood flowing up, but not being able to flow out much because there's a ton of systematic resistance due to that coarctation. So it's an airway or constriction of the airway, usually at a point of curvature, because maybe extra ductal tissue that extends into the adjacent aorta, resulting in aortic node. That ductus arterius area is usually what is a common reason for that. Usually presents in the first month of life. They don't even notice. They'll go home, and then we'll get called. So we can get called to calls like this. Caregivers unable to feel a pulse. Lower body cyanotic, but upper body's okay, right? Because the upper body's still getting perfused decently, but the lower body's not. So the blood's coming up, going up to our subclavians and our carotids. However, the blood flow that's going down to the legs is decreased. Patients are at risk for hypertension, ruptured aortic aneurysm, and stroke. Keeping the ductus open. So if we have that ductus arterius coming open, they have medications that can try and keep it. Not anything that we're going to give. However, it's usually needs surgery to fix it. Septal defects, a hole in the heart. So we have our atrial septal. There's a few of them that we're going to talk about. We have our atrial septal defect, opening between the two upper chambers, presents after birth, particularly the foramen ovale, right up here, right? We can see in this picture, normal heart, we know how all this flows. This one, this atrial septal defect, the foramen ovale is typically where it was at, it doesn't close correctly, but it could just be a hole in the heart, sometimes very small, sometimes it's pretty big. And it just causes this left to right shunt, causing this mixing of the blood and the extra work on the right side of the heart. Lets blood from the left atrium return via the hole in the right atria. Many times they have no issues. Sometimes they'll go years before they find out, and sometimes they end up not doing anything, depending on the size of the heart. Closing defect by surgery prevents serious problems. So if they fix it early, or it's not a big hole, but they fix it, then they don't have these issues later. However, sometimes they'll just let it go to see how it goes. Sometimes it'll heal itself. All right, now our ventricular defects. Opening exists between the two lower chambers. There's a loud murmur. This is one of the big sounds we'll hear, murmur. Blood from the left is still pumped right into that right ventricle as it's wanting to get pumped out to the heart. Much of it goes in the left and reoxygenates a lot. It becomes enlarged, and so you get cardiomyopathy. Defects large, surgery may need. Very similar, just usually more blood flow. So now our left to right shunt still, our patent ductus arterius, or PDA. Closure of the ductus arterius, the passage between the pulmonary artery and the aorta. So normal heart, everything going fine. On here, we have this patent ductus arterius, right here, patent ductus arterius. And so some of the blood goes back into the pulmonary system as opposed to, or the deoxygenated blood goes back to the entire system through the aorta and doesn't get oxygenated in the lungs, and so they'll be cyanotic many times. become fatigued quickly, grow slowly, and prone to pulmonary infections. They'll stimulate the ductus arteriosus, NSAIDs, or acetaminophen, right? Life-saving acetaminophen. Surgery may be required to restore normal circulation. So one where it's all right, and a lot of times they won't see it till later. Trunctus arterius, a single great vessel that arises over a large VSD instead of the normal two vessels. Not fantastic, as we can see here. And basically what happens is the pulmonary arteries and the aorta mix together. So what happens? They have this big ventricular septal defect. The blood then flows up into this giant vessel, and then it just kind of splits. So they're getting unoxygenated blood to the body somewhat and to the lungs as well. And then when the pulmonary veins come back to the left atria, it goes down. And so they just are a bit cyanotic. Decrease in peripheral vascular resistance because they don't have very much peripheral vascular. Increases the left to right shunt with evidence of heart failure. Ton of pulmonary hypertension. They have a ton of blood flow. You have your left ventricle pumping blood directly to your pulmonary arteries. They are pulmonary hypertensive. Shortness of breath, decreased exercise endurance, headaches, and dizziness. Need surgery. All right, valvular defects. Damage the defect in one of the four valves, almost frequently mitral and aortic valves. Valves may be stenotic, preventing them from closing fully. We have stenosis, which doesn't open all the way, and then you'll have regurg, which doesn't close all the way, and blood flows backwards. So this is not closing all the way, allowing the blood to flow backwards. Not opening, doesn't allow enough blood flow there. That's kind of it. Not a whole lot on this one. Just valvular dysfunction. Another one, we hear some of the extra heart sounds. Blood flowing in the heart chambers has greater tendency to clot, increasing risk of stroke or pulmonary embolism. Mild cases may have no symptoms. Advanced cases may lead to heart failure. Some of their symptoms: palpitations, mild chest pain, fatigue, dizziness, fainting, fever, rapid weight gain. All right, now we're getting closer and closer to the big one. So we're going to talk about single ventricular defects. One of the ventricles is underdeveloped. It's complex and rare. Prehospital care includes standard resus. End tidal may not be reliable, and it's not fantastic. So basically, tricuspid atresia, absence of normal development of the tricuspid valve prevents normal flow of blood from the right atrium to the right ventricle. Absence or abnormal development of tricuspid valve prevents normal blood flow from right atria to right ventricle. So blood comes in, our tricuspid's not closing well because it's defective, and so we have this as well as a VSD. Cyanosis and shortness of breath usually present until they can repair the connection between the arteries to the body and the arteries to the lungs. So the blood's flowing, kind of this defect of it not working very well. Pulmonary atresia. No pulmonary valve is present. Happens here. So this is a ductal dependent person. No valve here. The pulmonary artery doesn't connect to the heart. Opening the atrial septum lets blood exit the right atrium, so blood slowly mixes oxygen red blood in the left. Newborn appears cyanotic, and blood cannot flow from the right ventricle into the pulmonary artery and into the lungs. So this ductus arterius is the only thing keeping this kiddo alive at this point. So what we call this is it's a cyanotic condition, and they need to keep that open. They have medication for stenogladin. Hypoplastic left heart syndrome, the heart's left side. The aortic valve, left ventricle, mitral valve is underdeveloped. Returning blood flow from the lungs must flow through an opening in the wall between the atria. So we have everything going. Right ventricle's flowing well. It's flowing up here. Everything over here is not, the aorta's not flowing well. Left ventricle's not flowing well. Left atria is not flowing well. Everything's going through here. This is another one where the ductus arterius is huge on this. And it's the right ventricle is flowing both to the left and the right pulmonary arteries, and then also to the aorta. And it's the right ventricle is doing all the work. All right, now for the big one, tetralogy of Fallot. It involves 4 heart defects. Several famous people have had this. It's actually a relatively common thing. The reason it's common is because all the defects keep the kiddo alive. So you have a large VSD. So large ventricle septal defect allows oxygen-rich blood from the left ventricle to mix with oxygen poor in the right ventricle. Yeah, I got this great mixer here. Pulmonary stenosis causes it worked harder than normal to pump the blood. It's all stenotic in here through the pulmonary valve, causing the right ventricular hypertrophy. The right side starting to get bigger, and an overriding aorta is between the left and the right ventricle directly over the VSD. This is what keeps kiddo alive. So the pulmonary the overriding aorta comes right in here. It's right over the VSD. So this mixing of blood allows the blood to go up through here. That's stenosis, which allows doesn't allow a lot of blood through there, and when it does, it's causing this right side to work more. What this does cause, though, is all this to kind of flow through. This is another cyanotic defect. This is what we call a TET spell. Sometimes they don't find this till a little bit later, and it could be a couple months, something like that. Typically not too long. But so some things that can cause tetralogy of flows: German measles, rubella, or some other virals, poor nutrition, alcohol use, the age, mom can be older, diabetic mellitus, hereditary genetic features. Babies with unrepaired tetralogy of flow sometimes have hypotic TET spells. Sudden blood drop in blood oxygenation, severe cyanosis, often result into an activity such as crying, feeding, bowel movements. And what they'll do is they'll tuck their knees up into their body, and what it causes more blood to flow back to decrease vascular return, and basically they're keeping their blood in their extremities and causing a decreased vascular return, which causes a release, their heart to not have to work as hard, and so that overworked right side side of the heart doesn't have to work as hard, and so surgically repaired younger in life, and usually they do pretty well after surgically repaired. All right, another big one: transposition or reversal positioning of the aortic and the pulmonary arteries. Systematic pulmonary circulations are in parallel rather than in series. Oxygenated blood, poor blood returns from the body is pumped out to the aorta, and oxygen returns from the lung is sent back to the lungs. If they find this quick and treat it, 90% survival rate. But we can see here, it's coming back, and it goes through, right? Typical heart. Pulmonary aorta comes in, and so it just feeds each other. The aorta, so the vena cava comes in, right atria, right ventricle, goes up directly to the aorta and out to the body. The blood in the circulatory system is just running on its own, going from pulmonary veins, right atria, or left atria, left ventricle, pulmonary artery, and back. And so that's switched, and they need to fix it. Total anomalous pulmonary venous return, TAPR. 4 pulmonary veins that carry oxygen-rich blood back to the heart from the lungs are not properly attached to the left atrium. They're improperly attached to another area, usually vena cava. So the oxygen-rich blood that should return to the left atrium instead mixes with oxygen-poor blood. Blood mixes to and from the lung and never to the body. Just all around in there. They'll appear critically ill of lethargy, poor feeding, rapid breathing, poor growth, frequent respiratory tract infection, cyanosis. All right, getting away from the heart, we have intestinal malrotation. We have basically all the lining that normally keeps our small intestines in its correct positioning, all that feet and yards of intestinal length is now malrotated and out of whack. Basically, around the superior artery it causes a rotation as it goes down. Occurs in 1 in every 500, becomes evident after the first week of life. 90% are diagnosed in the first 12 months. Recurrence of bouts of abdominal pain, diarrhea, intolerance to solid food, jaundice. So typically, usually when it does get found, if it's made it long enough, it's because when they start moving to a more solid diet, their body does not do well. And it's just a huge GI issue. So they'll go in there and surgically fix it. Pyloric stenosis. Our pyloric valve right around here becomes very stenotic, narrow. Most common cause of intestinal obstruction. Diagnosis usually made with history, progressive forcefully vomiting, dry mucous membranes, slow capillary fill, sunk fontanelles, decreased output. They just can't get anything in their stomach, so then they can't absorb new fluid, and so now they need to get in. They'll fix those vessels around there. Relatively easy to fix. Kind of what they do there. Anomalies of the abdominal and lower back, congenital diaphragmatic hernia. We talked about this earlier. Here's all the issues that they had. We've talked about this earlier. I'm not going to go in depth with it again. Gastroeresis. This is one of the ones I was talking about. So this abdominal wall defect, it allows the intestinal and abdominal organs to herniate through the abdominal wall out into the abdominal fluid, usually to the right of the navel. Occurs more often in babies born of younger mothers. Occurs in approximately 1 in 5,000 live births. No sac over the organs. This is different than the next one. Amophilocele. Intestines not recede back into the abdomen but remain in the umbilical cord. First seen in ultrasonography during prenatal care, occurs in about 2 in every 10,300 live births. Size and location may vary. If the sac is ruptured, it's it's difficult to differentiate from gastroeresis. All right, and for these last ones, we have our spinal bifidus. It's basically separated into 3 separate spinal versions ish, all depending on the severity involved in the spinal cord and how bad it'll get. So basically what happens is part of one or more vertebrae fails to develop completely, leaving a portion of the spinal cord exposed. It may occur anywhere in the spine. Most common location is the lower back. About 1,500 babies are affected per year. Evidence decreased by about 20 to 30 when folic acid supplements were recommended by the U.S. Public Health Service. Some risk factors: extremes in maternal age, previous birth affected child, and basically by how much of the neural tube / the spinal cord is exposed. No cure, but surgeries can help. And we'll go over the 3 different versions. So in here we can see normal spinal cord, and they have this developing outside of this spinal canal. Depending on how much of the cord and the nerves come out, depends on how bad this gets. So the 4 types: spinal difficult, little evidence, external evidence, most common, least serious. Next one, meningocele. Nerve tissue is intact, covered with a membrane sac of skin, does not cause functional problems, but does require surgery repair. Raw swelling of the spine and malformation of the cord may or may not be in a member sac. And there are the next one, and the most severe leaves child handicap, and we'll go over that. And so you can see occulta just have this little bit of issue of a vertebrae not being there correctly. Meningocele, it comes out, and you have CSF out here, but the cord is still intact. And then myelomeningocele, where the whole entire cord's coming out, and this is the most severe, and this is where they develop the most issues. Almost the worst severe. The most severe is this one, is the encephalopathy of seal. Protrusion occurs through the skull. Severe brain damage common. It's very rare. At delivery, defects should be covered in sterile gauze soaked in normal saline. Part of their brain is formed outside of their skull. This one's obviously the most severe. Third one, as far as overall, definitely of a concern. So last part, blood pressures. Back into the stable portion. Blood pressure, 2 phases of shock, compensated, uncompensated, irreversible, but basically the 2 phases that we're going to be talking about. Cardiac output, sustained heart rate greater than 180 beats per minute at rest is considered tachy for neonates. Remember, cardiac output is heart rate times systolic or stroke volume equals cardiac output. In addition to electrolyte, mineralolyte, and energy imbalance factors that can impair cardiac output include the following: decreased volume of venous return to the heart, so less blood getting to the heart, increased systematic resistance after load, and decreased myocontractility, the squeeze of the heart. We went over these before. Increased respiratory rate, apnea, gasping, cyanosis, desaturation, pale white skin may also indicate hemoglobin secondary to hemorrhage. Other signs of shock: heart rate, normal heart rates between 120 and 160, 80 to 200. Kiddos will get up to 200, crying and all that. Not a huge concern. Sustained Sustained above 180 or higher at rest is obviously where this shit comes up. Bradycares, food shop. I'm assigned they're going to code soon. Just be aware. Other signs may include hypothermia, increased ICP, abdominal distension, hypoglycemia, episodes of apnea, and have to roll out a complete heart block. Heart block might be the only time we actually end up pacing these kiddos. Tachycardia may indicate poor congestive failure. Heart rate's above 220, consider DVT. Other signs of shock. Blood pressure may be low. Maybe within normal ranges because of vasoconstriction and centralization of blood pressure during compensated shock. Presence of hypotension signals uncompensated shock. So they're tachy, but not hypotensive yet. We're considering that compensated shock. As soon as they become hypotensive, we are now considering that uncompensated shock. Pulses are going to be any weak peripheral pulses. If the brachial pulses are stronger than the femoral pulses, consider coarctation of the aorta or interruptic aortic arch. Kind of we're talking about those heart defects, right? If outflow tract is obstructed with complete ductal closure, all pulses will be weak or absent. Peripheral pressure, poor pressure, secondary vasoconstriction, poor cardiac output, poor capillary refill greater than 3 seconds, cool or mottled skin, cool, pale, and or mottled skin are all signs of shock. Heart, we're not going to see chest ray, smaller than normal, compressed heart, evaluate for presence of murmur, so on and so on. Urine output less than a milliliter per kilogram per hour, or declining urine output, especially the other signs of hyperperfusion. That's why it's important to ask how many diaper changes they've had and how many they normally have. 3 types of neonatal hypovolemic shock. Acute blood loss during the interpartum period, so placental hemorrhage, umbilical cord injury, organ laceration, fetal to heart maternal hemorrhage. Twin-to-twin transfusion, where one kiddo starts getting more blood than the other. This can only happen with a single placenta same gender fetus, weight discordant of greater than 20% amniotic fluid discordance. With that, postnatal hemorrhages, brain, lung, adrenal gland, scalp, and we'll go over the scalp bleeds here in a bit. Obstructional etiology, tension pneumopericardial in the pericardial sac. We don't see that often outside of neos. We can in certain traumas. And then other hemorrhagic causes, umbilical cord accidents such as nuchal cord, prolux cord knot, cord entanglement, blood flow where the blood flow to the fetus is interrupted, severe capillary leak secondary to infection, and dehydration. So sepsis and dehydration. Cardiogenic shock are intrapartum and postpartum asphyxia, hypoxia, or metabolic acidosis. Bacterial viral infections, all these. We can also see all the same reasons that we can see it in adults, same that we can see in kids. Infants with septic shock, they become sick real quick. They don't respond well to fluid. All their fluids third spacing. They need pressors, and they have a high morbidity and mortality. We need to get on top of these fast. Try and identify the cause, then try and fix it. That's how we treat it, right? No acute blood loss, 10 mLs per kilogram, dose over 15 to 30 minutes. If there's acute blood loss while awaiting PRBCs or whole blood, aka we're driving, 10 milliliters, same dose, 30 minutes to 2 hours. Treatment is aimed at correcting underlying problem. May require more fluid bolus than other type of shock. A continuous infusion of dopamine may be necessary. Same dose range as adults. All right, as I was saying, the scalp swellings. Common finding in neonates, we have 3 different types. We have septum succedia, cephalohematoma, and a subgeal hemorrhage. There's one that's really bad. The other 2 are okay. AKA cone heads. All right, here's where we start. The first one. Swelling of the soft tissues of the scalp may be observed. Superficial recedes relatively quickly. The swelling may shift as the infant is moved. Bruising may be noted in the area of swelling. All 3 types of swelling may look similar, but here's some of the difference. With the first one, location. Edema of presenting part of the scalp usually crosses the suture lines. The palpation is soft and spongy, so it's usually kind of bigger and all over. Pits on pressure. Blood loss is minimal. Usually resolve itself 48 to 72 hours. Here's how it looks inside. We have these sutures. So the first one goes over all the sutures, just kind of big over there. Second one, cephalohematoma. Periosteum is a membrane of connective tissue that wraps around the bone. Hemorrhage that occurs underneath the periosteum of the skull is called cephalohematoma. The periosteum limits the extension of the hemorrhage, therefore the swelling will not cross suture lines. Stops at the sutures, maybe bilateral palpation initially more fluctuant the first 48 hours. Rarely severe. X-ray needed if skull fracture is suspected. Usually results 2 weeks to 3 months. Finally, subgeal hemorrhage. Venous return from the blood is usually gone through the emissary veins to the dural sinuses, then down to the heart. Rupture of the emissary veins can occur during a vacuum-assisted delivery or with a forceps-assisted delivery, also called operative vaginal delivery. When those emissary veins rupture and bleed, they bleed into the supraneurotic space, which is located above the peristeum. Unlike cephalohematoma, which has a peristeum to limit the spread of the bleeding, there's no barrier to stop the bleeding, therefore subgeal can be massive. Locations across the suture lines may extend from eyes to the nape of the neck. Firm reflection body dependent on swelling. Blood loss may lead to severe anemia and hypovolemic shock. Resolves over 2 to 3 weeks if it does have high morbidity. They can lose a ton of their blood because there's not those suture lines stopping them. It just arterial bleeds and bleeds and bleeds, and this is why it's a subgeal hemorrhage is a pretty big issue. It's right here, and it just goes and goes and goes. Labs, ready for this one? Join Neo team. We don't have to worry about in the field. Sugar, but that's at the beginning. So, emotional support. Be there for the parents. So if the kid is going wrong, have them involved in it. Whether it's deceased or not viable, we need to talk to them. Be supportive of them because they can now be your patients. Tips is a great resource. All right, guys. Super long one. Hope you guys got a little bit out of this. I'm here if you guys have anything. Let me know if you have any answers. Questions.